Okay, time. Welcome everybody. Welcome to this session on mechanical ventilation with a lot of exciting talks. My name is Laurent Brochard. I'm from Toronto, and I'm delighted to co-chair with Patricia Rocco from Rio de Janeiro. And we'll start right away with Danny Talmor from Boston asking a low tidal volume in all patients. Danny?
Thank you. So my topic is low tidal volume for all, and I hope to persuade you, and I hope at the end you'll understand in which direction. So a short history of tidal volume. As you know, mechanical ventilation came from the operating room into the ICU, and the initial teachings from the operating room were based largely on this paper from 1963, where they examined the desaturation during mechanical ventilation in the operating room, and they found that patients with lower tidal volumes would drop their PaO2 substantially during surgery. At the time, it was thought that it's important to maintain a high PaO2, and higher tidal volumes would do that. So they recommended, these authors from Harvard, that you continuously use large tidal volumes with periodic deep breaths, which we would today call a recruitment maneuver, and that's essential to reduce the shunt. When ARDS was first described, Dr. Petty, who was one of the initial people to describe that, gave these recommendations for mechanical ventilation. Use of a high tidal volume ventilation with inspiratory plateau and positive end expiratory pressure improves oxygen transport across the lung, and improving and maintaining oxygenation was considered to be critical. Now, we of course learned a lot over the 70s, 80s, and 90s about what happens to the lung during ARDS. These pictures of baby lungs tribute to Dr. Gattinoni, who we lost this year, who first described the fact that when we look at a chest X-ray, we see a phenomena spread across all of the lungs, but when we look at a CAT scan, we see that there are areas that are sicker than others, and we're left ventilating these small baby lungs. So through that process, ventilator-induced lung injury was described as being a combination of stress on the lung, which is high pressure, strain on the lung, which is high tidal volume, together with cyclic collapse at end expiration, which is atelectasis. And if you repeat that over and over again, 10, 20, 30 times a minute, in the right kind of lung, which is a sick lung, you can get lung injury and exacerbate the patient's condition. So taking that into account, a number of trials were launched looking at lower tidal volume ventilation over the late 90s. The most famous one was this, the ARDSNet low tidal volume study, and they addressed both stress and strain. So they reduced tidal volume, but they also limited plateau pressure. So they reduced tidal volume to 6 mLs per kilo versus 12 mLs in the control arm. And the difference between those two graphs is the reduction in ventilator-induced lung injury due to restriction both in tidal volume, but we often forget this, restriction in the plateau pressure. Now, many subsequent trials tried to answer the question, is this important in patients who don't have ARDS? Now, where do you have tons of patients who don't have ARDS that are getting mechanically ventilated? It's, of course, the operating room. So I won't go over the individual trials, but I'll show you this chart from the meta-analysis that was done. And you can see in this study, these studies, they essentially replicated the ARDSNet formula. So 6 mLs per kilo in the control arm and 10, 12, or larger mLs per kilo in the intervention arm. The control was 6. And they showed a difference. So there was less lung injury, there was lower mortality, less pulmonary infections, although unclear why, and marginally less atelectasis in the patients who received the 6 mLs per kilo. So on the face of it, it would seem that lower tidal volumes are better in patients without ARDS. But the same group did a second meta-analysis to look and see if there were actual limits to the tidal volume. And what they found is if you had a tidal volume of less than 7 or between 8 and 10 mLs per kilo, essentially there was no difference. Really, the harm in these trials was driven by the patients who received more than 10 mLs per kilo of tidal volume. So it doesn't appear on the basis of this that maintaining 6 mLs per kilo is the holy grail that we have to strive for in every patient with and without ARDS. And you know, as I travel and see other ICUs, not so much today, but in years past, 6 mLs was really viewed as a hard stop, and every patient had to get that. So based on this, maybe not. And if you go back and look at the original ARDSNet trial, there were problems there. So this editorial by deans and collaborators from the NIH came out a couple of years after the ARMA trial and really slammed the trial. So just to look here, these are patients who were excluded from the trial for various reasons. So patients who refused enrollment, patients whose doctors refused enrollment, people who met various exclusion criteria. And you can see there are actually a couple of thousand patients who were excluded from the trial. And the mortality in those patients who were excluded from the trial was the same as those who received the 6 mLs per kilo of tidal volume. So you have to ask yourself, was it the 6 mLs per kilo that saved people, or was it the 12 mLs per kilo that actually hurt people and drove the results of this trial? Because all of these excluded patients continued to receive standard of care ventilation at the time. And it wasn't random, the tidal volume that those patients received. So here you can see on the one side of the graph, on the left-hand side, the compliance of the patients in the trial who were enrolled in the trial. So this is pre-randomization data. You can see on the top is the higher compliant patients. On the bottom is the lower compliant or sicker patients. And then if you look at the plateau pressures and tidal volumes that those patients received, so the higher compliant patients, so the non-sick patients, had lower plateau pressures and higher tidal volumes, while the sicker patients had received lower tidal volumes and had higher plateau pressures. So it seems that the tidal volumes pre-randomization weren't actually random. Providers were giving higher tidal volume ventilation to patients who were not sick. And that would indicate that those patients actually received safe ventilation. Their plateau pressures were relatively low. And what happened when those patients were randomized? And this is the real killer slide. So if you look at the patients with a lower pulmonary compliance, those are the dark circles, when those patients had their tidal volume lowered, so they were randomized to lower tidal volume, their mortality improved. When they were randomized to higher tidal volume, their mortality got worse. So that mirrors the results of the trial. But if you look at the higher compliant patients, the less sick ones, if you lowered their tidal volumes, you increased their mortality. So in healthy lungs, lowering tidal volumes seemed to increase mortality in the ARMA trial. If you raise their tidal volume, they did better. So this would indicate that we should not be reducing tidal volume in all-comer patients. And pay attention to the date. This is data from 20 years ago that was out there in the literature. Now remember, the ARMA trial really had two interventions, lowering tidal volume and lowering plateau pressure. And the relationship between tidal volume and plateau pressure, as you can see here, is completely random. So it's patient-specific. There's no rule to it. And we have to look at each individual's patient before we decide which to lower. And that goes for the transpulmonary pressure and tidal volume. So not just airway pressure, which is influenced by the chest wall, but transpulmonary pressure as well has no clear relationship between delivered tidal volume and transpulmonary pressure. So in fact, tidal volume may not even be associated with mortality. So this is data from Checkley in the Blue Journal in 2008. On top are the relationships between tidal volume on the left and plateau pressure on the right in a univariate analysis. But controlling for all patient factors on the bottom, C and D, you can see that in D, the plateau pressure continues to be related to patient mortality, but tidal volume no longer related to patient mortality when you control for all other factors. So, in fact, the ARDSNet finding might have been correct. It just wasn't tidal volume that was the important factor there. So the risk factor of tidal volume is U-shaped, and that's true of pretty much every variable in medicine. So if your potassium is low, you'll die. If it's high, you'll die. If your tidal volume is too low or too high, you'll die. But where is that sweet spot? It's probably compliance dependent in the individual patient. And we need to take into account the individual patient's compliance when considering the tidal volume. What do clinicians actually do? Always worth asking ourselves. So this is 6 mLs per kilo there. You can see that worldwide in the lung-safe trial published 10 years ago, some patients, but a minority of patients were receiving 6 mLs per kilo. And these are patients with diagnosed ARDS. Very few patients were receiving over 10 mLs per kilo. So remember that the control arm for most low tidal volume studies was 12, actually indicating something clinicians wouldn't do. Most clinicians wind up in that sweet spot between 6 and 10 mLs per kilo. Now, when this first came out and I looked at it, my first reaction was, oh, we need a lot of work in education. But I think it's not poor practice, it's collective wisdom of the providers who understand that 6 mLs per kilo may not be the be-all and end-all of lung protection. So how do we tie it together? Well, let's look at the driving pressure. And the driving pressure, as everybody knows, is the plateau pressure minus the PEEP. And you can convert that to the compliance is the tidal volume divided by the driving pressure. And then driving pressure is the tidal volume divided by the compliance. So driving pressure is the tidal volume size to the compliance of the respiratory system and may well be a better marker for setting our mechanical ventilator than actually just limiting tidal volume in everybody. So how does that look on a P to F curve? So this is a high tidal volume, no PEEP breath, and you can see the driving pressure, that red arrow on top is high. If we target our driving pressure, we're looking at a higher PEEP at lower tidal volume, and that will reduce it. And we know that reduction in driving pressure is associated with improved mortality from the original paper. We've looked at data from the EPVent-2 trial and seen that if you combine, it's a little hard to tell here, but if you combine a driving pressure, a lower driving pressure, less than 12, or together with PEEP set to a transpulmonary pressure of 0, you receive a better outcome than if you do one or the other individually. And this small trial out of Brazil has shown that you can target driving pressure in your mechanical ventilation. So they randomized patients to driving pressure driven ventilation versus ARDSNet ventilation and found that you can actually manipulate driving pressure at the bedside to achieve a targeted ventilation. So low tidal volume for all, I would say no, it's not necessary in all patients. Low tidal volume in patients with healthy, compliant lungs may lead to a worse outcome. So the key is to look at the lung compliance. And if you have a healthy patient in the operating room or somebody who comes to the ICU for a reason and is ventilated for a reason not to do with their lungs, look at their compliance, target a driving pressure below 12, that's probably a good target. But if that driving pressure below 12 is a tidal volume of 8 or 10 mLs per kilo, that's fine. That patient will do well. There's no need to drop the tidal volume to risk de-recruiting those lungs and to cause damage from that low tidal volume. And finally, a word of caution, pay attention to the respiratory rate. often tidal volume is dropped and respiratory rate is increased. And if we go to the new target for mechanical ventilation, which is mechanical power, by doing that, you'll actually increase the mechanical power by delivering that harmful breath more frequently. So to sum up, low tidal volume for all, a resounding no. Thank you very much.
Thank you very much, Danny. So we'll take a few minutes after each presentation for questions. I have to say, I cannot see anything in the room. It's all dark, but yeah,
I
see you.
Oh, there's one here.
Perfect, thank you.
Markus Krivars, Helsinki, Finland. Thank you. Very nice talk. A little bit different question, perhaps, but what's your view on the patient who is on pressure support ventilation, being weaned? They have good lungs, but they have this huge respiratory drive, and they breathe high tidal volumes without any pressure support, and some think this is very harmful, and you can't really do anything about it except sedating the patient, which probably is not a good idea.
Yeah, so that's a great question. It's actually a completely different question, but you know, patient self-induced lung injury is a major topic that we all need to pay attention to, and those patients that you described are unfortunately common and difficult to deal with. So my approach is to try to wean them, to extubate them as quickly as possible, avoiding damage from the ventilator and the side effects of the sedation. If that's not possible, you may just have to live with it. And I'm sure there's other talks at this meeting on the exact same topic.
Thank you. Patricia?
Congratulations, excellent talk. And since you are here, I have to explore you, you know?
Okay.
And of course, I'd like your opinion related to the use of the esophageal pressure, you know, in obese patients or in COPD patients, where the compliance is completely different, depending on the degree of the severity of COPD. How do you ventilate these patients, you know, about, of course, the tidal volume?
You don't have to do everything from obese
No,
to
no,
COPD,
no,
right?
no, no,
Yeah.
no, no. But you can focus on COPD, it's okay.
Well, I'll actually focus on obese because
Okay.
it's more personal for me.
It's not licking me.
The thing to remember about esophageal pressure measurements is you're actually measuring the weight that is collapsing down on the lung. So in obese patients, it's very clear that esophageal pressure measurements are extremely useful in setting PEEP to avoid the weight of the chest and the weight of the lung collapsing down on itself and causing atelectasis. So in those patients, it's completely clear that esophageal pressure measurements to set PEEP are the way to go. After that, I think if the patient is sick, then I would use low tidal volumes and target driving pressure. If the patient is not that sick and their lungs are healthy, remember, under the layers of fat, the lungs are the same size. So I would do whatever I would do in any other patient, which if they're healthy lungs, set them based on driving pressure and not obsess over 6 mLs per kilo. COPD, I have to admit, I'm not an expert in that, but I think the same principles hold. If the patient has collapsed lungs for whatever reason, setting PEEP based on esophageal pressure makes sense. And then regarding the correct tidal volume, I think, again, there we could probably follow driving pressure, but I leave that to people who are more expert than me.
Thank you so much. Excellent answer.
Thank you very much.
Thank you.
Take the next one.
Yeah, absolutely. So let's move forward, and I have a pleasure to invite Professor Ferguson from Toronto, Canada, and he will talk today about using physiology for personalized mechanical ventilation. Thank you very much for coming here.
Thank you very much. Great. Okay, so thank you very much for the invitation to be here. Thanks to the organizing committee. And my talk for the next 15 minutes is to talk about sort of precision medicine, but not using biomarkers and biology for the most part, actually applied physiology at the bedside to allow us to personalize mechanical ventilation. And due to time constraints, I'm going to give examples based on the setting, how to set PEEP, and also following on Danny's talk, thinking about using driving pressure. These are my disclosures, nothing particularly relevant for this talk. Lots of ways you could set PEEP. You could just say, okay, 8, there it is. You might use a plateau pressure minute. You could use a PEEP FiO2 table. All sorts of physiological measurements could also come into play. Whenever I talk about setting PEEP, I always like to reference and remind people about this classic paper from 1975 in the New England Journal, Peter Suter and Barry Fairley, showing that best PEEP, and we've been arguing about what best PEEP could be for the subsequent 50 years. In their definition, this occurred when compliance maximized, when oxygen transport maximized, and interestingly, it was inversely proportional to the baseline functional residual capacity, or how small the baby lung was. And so I think this paper should be in every practicing intensivist's library. What we do in the real world, Andres Esteban and colleagues have shown us that over time in the early part of the 21st century, we saw mild increases in set PEEP, although practically most of that was due to elimination of people using extremely low levels of PEEP, as opposed to us really adding more. And from LungSafe, as we've already referenced today, set PEEP remains modest, I would say, on average. 8.4 centimeters of water overall, and even in the severe ARDS group, only an average of 10 centimeters of water. And is this the right level? Well, maybe not. There may be room for improvement here, and it may be actually corresponding with improved outcomes when we use higher PEEP in appropriate patients. A reminder that when we set PEEP, it's not so much that it's not about atelectasis being bad. In this experimental study from Brian Kavanagh's lab, you can see that when they provided injurious mechanical ventilation to lungs and then looked at the overall injury score in the dependent and non-dependent regions, the lung injury is happening in the non-dependent regions where the actual ventilation is happening. So it's not just about preventing atelectasis, it's about expanding the size of the baby lung that's available to help offset and protect the non-dependent lung regions. Luciano Gattinoni's classic paper from the New England almost 20 years ago shows us that, in fact, recruitability is a key factor when we think about who should get higher PEEP. Patients like this, when you go from 5 to 45 centimeters of water and you get lots of lung recruitment, might be ideal candidates for higher PEEP. Whereas patients like this, non-recruiters, we should not be using higher PEEP. Important to recognize that here that the starting panel on our non-recruiter looks actually pretty similar to our post-recruitment example in the recruited lung. And when you take lung that's already open and try to recruit it, what do? It's obviously not recruitable. You end up over-distending it, and you have huge effects on the hemodynamics by squishing the heart and reducing venous return. So you could use a PEEP FiO2 table to set PEEP. And lots of people malign this as being too formulaic. But actually, if the patient's reading their physiology book correctly and they are a PEEP responder, then this actually might work and help you set higher PEEP in patients who are more recruitable. This has been tested in several large trials using higher versus lower PEEP while keeping tidal volumes at 6 mils per kilogram and plateau pressures of 30 or less. And although these 3 individual studies didn't show a difference, when you put them together in an individual meta-analysis, there is in fact a signal for benefit with a higher PEEP strategy. And if you want to use a physiological argument to this, interesting to note that using data from that same Gattinoni CT study I showed you before, it was only the PEEP FiO2 table approach that actually led to giving higher PEEP to patients who are more recruitable, in contrast to using esophageal pressure or stress index in this example. Another way to think about PEEP is to measure the recruitment to inflation ratio. This is something developed by Lu Chen and Laurent in Toronto a few years ago. And I know some people's eyes glaze over as soon as they see volume pressure curves. We'll walk through this a little bit slowly. It's called the recruitment to inflation ratio. It's actually more technically the de-recruitment to inflation ratio. And what this allows you to do is to say, if I'm already using, is the high PEEP that I'm already using actually preventing de-recruitment? And in a single breath, when you drop PEEP from 15 to 5, for example, you watch and you see how much extra tidal volume is expelled in that single breath, and how much of that is related just to expected deflation. You know, if I have a balloon and it's at 15 centimeters of water, and then I let air out of the balloon until it's at 5 centimeters of water, there's a certain amount of volume that comes out of that, depending on the respiratory system compliance of the balloon, or the patient in this case. And then we look to see is how much more than that just deflation came out, and that's the de-recruitment portion. I'll show you more about this in a second, but just as a side note here, the other thing here, so this is the ratio, the compliance of the recruited lung versus the respiratory system compliance at the lower PEEP, or the AOP. What's the AOP? The airway opening pressure. Look on this volume pressure curve, these two volume pressure curves here. Here, you just see a straight line. As you increase pressure, volume goes up fairly linearly. On this example, what happens? First, pressure goes up a lot with very little volume, and then suddenly there's a huge inflection point, and we get back to a linear line that looks like the other example. And this slope here is the slope of the respiratory circuit with the airway occluded. So this is an example of airway opening that looks to happen or airway closure with subsequent airway opening with pressure, that looks to happen in up to a quarter or a third of patients with ARDS, more in patients who are morbidly obese. You can detect this, sorry, I got my slides out of order here. You can detect this in an easy way. I'll show you in a second. This is the last slide on recruitment to inflation ratio. You can see here, here's our pre-breath, here's our single breath as we went from PEEP of 15 to 5, and those are the two values that you're going to use to calculate the RI ratio. At the bedside, you can do this very handily by going to this website put together by one of our star respiratory therapists in Canada, Tom Pereno, rtmaven.com, and we'll help you with bedside calculations. You just plug in the raw numbers, and it'll spit out the numbers that you need. Here's the graph I wanted to show you about airway opening pressure. You can do this in a number of ways. If your ventilator has a PV tool on it, that's probably the fastest, easiest way to do it. Just hit the PV tool and look for that inflection on the volume pressure curve. If your ventilator doesn't have a PV tool, no problem. You can set up a single slow inflation. So look at the volume down here. The flow is going in at 5 liters per minute. And here's an example where you see a rapid increase in pressure, in airway pressure, despite very little volume having gone into the patient. And then, boom, airways open, a major deflection in the slope of the pressure time curve. And here we have an example of an airway opening pressure of 19. So any PEEP that you have set below 19 centimeters of water in this patient, for example, would be doing nothing. You also use electrical impedance tomography, and this is a nice example from Marcelo Amato's group, and that might help you find the best trade-off between atelectasis and lung collapse versus overdistension, which is always happening in different areas of the lung. And just these examples show us that here's the example here, which in this patient corresponds reasonably well with the overall compliance of the respiratory system, but it's not always the case. And this one is a different example there. One sneaking a little bit of biology into this precision medicine talk. We're all familiar with Carolyn Calfe's work, latent class analysis, showing two different phenotypes of ARDS, one hyperinflammatory and one slightly less hyperinflammatory, the hypo group. The very interesting thing about this is how they track with heterogeneity of treatment effect and response to PEEP in this example from the alveoli study, which I'll remind you was overall no effect. If you were a patient in the hyperinflammatory group, the smaller phenotype 2 here, significant reduction in mortality, 51% versus 42%. If you were a patient in the more prevalent so-called hypoinflammatory group, mortality went from 16 to 24%. So the way in which we use PEEP has important implications in individual patients, and it depends. You can also predict some outcomes just looking at patients' oxygenation response to PEEP. In this secondary analysis of the LOVES higher versus low PEEP trial, we looked to see if patients' PF ratio patients had PEEP that was set to either higher or lower in the random groups, but the actual delta PEEP depended also on what their baseline PEEP level was. So we took the difference in PEEP from baseline to first blood gas measured afterwards, roughly about an hour and a half afterwards. And in patients whose PEEP was increased, there was a strong relationship between PF ratio and outcome. So if your PEEP went up and your FiO2 got better, and your PF ratio improved, great. If your PEEP went up and your oxygenation got worse, that was a significant problem. And we didn't see that relationship when PEEP was the same or lower, suggesting that it wasn't just related to patients getting better or getting sicker. So I've tried to show you here that atelectasis itself is not harmful, but its secondary effects on the baby lung are that lung recruitment with higher PEEP generally improves mortality in patients with moderate to severe ARDS, but it's underused in clinical practice. But overall, while successful lung recruitment is good, increased PEEP without recruitment may be bad. So what do I do in real clinical practice? I usually start with a PEEP FiO2 in most less complicated patients. If they're already on higher PEEP, we check the R to I ratio, and if the patient's not breathing spontaneously, we'll also measure the airway opening pressure. And in severe ARDS patients, thinking about a decremental PEEP trial using compliance, thinking about potentially using an esophageal balloon and or a EIT device, and assessing our response to PEEP, both with oxygenation and hemodynamics. In the last couple of minutes, just to switch gears and talk about ventilator-induced lung injury, we generally want to think about keeping patients in this safe window, avoiding overdistension and derecruitment in atelectasis. And while Danny already showed us these data showing that 6 mLs per kilogram and plateau pressures less than 30 resulted in a significant reduction in mortality, there's debate as to why that is, as we heard. And there's data to say that this is not the be-all and end-all of lung protection in all patients. We saw these driving pressure data already, brought to us from Marcelo Amato, clearly an association between this is static driving pressure on day 1. My colleague Martin Erner has also extended this using dynamic driving pressure and showing harm on every day of mechanical ventilation out to day 8 with higher driving pressures that's accentuated at lower PF ratios. And why is this important? This is a secondary analysis of the ARDSNet study showing that all of this difference in mortality was driven by patients with high elastance or low compliance. In other words, it was driving pressure, it was lowering driving pressures when they were high in some patients, or making them high in the control group, that led to these differences in mortality, it seems. This has given us hypotheses to test and saying, should we be focusing on driving pressure exclusively and not caring at all about tidal volume, even in ARDS patients? And this is a large platform trial that is really a global collaboration run out of Toronto, where one of our first large international studies is the DRIVE randomized controlled trial. And we're randomizing patients all around the world to a guideline-based tidal volume less than 6 mLs per kilogram and plateau pressures less than 30 versus a driving pressure limited approach. And I hope to be back here in a few years to give you the results. Thank you very much for your attention.
Congratulations. Questions from the audience? Please.
Neil, thanks a lot. You touch upon 2 things which are very fashionable. One is personalized medicine, and one is RCTs. So, and you described very well the way you could individualize. Do you think it's really compatible with RCT, where you have a lot of centers with different experience and you try to simplify things, right?
Yeah, I think you're right, Laurent, in one sense, doing, especially a multi-center RCT, international RCT, is an ongoing compromise between what you would do if one was at the bedside individually looking after this patient versus what you can try to protocolize across the world. And I think that really we need RCTs and physiological experiments to work together. They're not one does not trump the other. I think RCTs that we should use physiology to drive our hypotheses and interventions in trials as much as possible. We should embed that physiology within the protocol. And then when we get these results, then we're going to try and go back and look at using some physiological principles, looking at subgroups, looking for the holy grail of individual, but maybe we can get to individualized heterogeneity of treatment effects, as opposed to just saying, oh, one level for everybody.
Excellent. No questions, but I have one.
Okay.
It's like a routine to measure the elastance or compliance at the bedside. But what about the other physiological parameters that need to be performed? We have a full room here, and I believe that it's so important to measure not only the elastance or the compliance per se, but the other physiological parameters. What's your opinion related to this issue, and which are the other parameters that you think that we have to do frequently as a routine at the bedside?
Great question, thank you. I think like this is also where we can personalize things. There are some monitors that we apply to every patient. Every patient gets pulse oximetry, every patient gets capnography, but as you get more complex and they're more invasive and have risk for them, then we need to tailor what we're doing for an individual patient. So I think that we should be measuring compliance. I think we should be measuring, and I think that, we'll hear more about this later probably, but in spontaneous breathing patients, I think that we should be thinking about, and maybe we don't know exactly what to do about it yet, but I think we should be informing ourselves of how much are patients breathing, how much efforts are they making, how much pressures are they generating to, which we're generally blind to on the ventilator unless we make some special maneuvers. And then in individual patients, do we put in esophageal pressure? Yeah, in some patients, looking at using electrical impedance tomography for monitoring in some patients who are either those who are breathing spontaneously and I want to know, is there a lot of pendulift happening, or in patients who are very difficult to oxygenate, and I want to make sure that we have the right peak level.
Excellent, fantastic. Any more questions from the audience? No? So, thank you so much.
Okay, the next speaker is Jose Dianti, who was in Toronto and is back in Argentina, and is going to discuss about monitoring respiratory effort and lung-distending pressure.
Sorry, that's not my slide. Oh, that one. Yeah, perfect. Okay.
Well, you have to.
I'll wing it. Okay. Thank you for inviting me to this amazing conference. And my talk, incidentally, even as it looks as it was planned, is going to be about monitoring respiratory effort and lung-distending pressure, specifically in patients who are breathing spontaneously. And it will hopefully build up a little bit on what Dr. Talmor and Dr. Ferguson were just talking about, and on what Dr. Roca was just actually asking about. I have nothing to disclose in terms of conflicts of interest. So why would it be important to measure respiratory effort and lung-distending pressure when patients are breathing spontaneously? Well, the moment we start mechanical ventilation on a patient, we immediately think that these patients might be at risk of ventilator-induced lung injury, and as it was very elegantly described in the two talks that preceded me, ventilator-induced lung injury is most likely related or primarily related to increases in lung distending pressure. So the number one intervention, the one that has, as explained before, decades of research in our field, is to reduce tidal volumes and limit plateau pressure and probably driving pressure as well, with the goal of reducing the lung distending pressure. In order to do this, it is often necessary to also abolish respiratory efforts, and this is because patients who are receiving low tidal volume ventilation with low plateau pressure ventilation often present significant asynchronies or potentially excessive respiratory efforts that make this reduction in lung distending pressure difficult to attain, and we tend to abolish respiratory effort with deep sedation and eventually paralysis. And this might also lead to conflicting side effects or competing events of diaphragm disuse atrophy, which has also been shown, albeit not in RCTs, but has also been shown to negatively affect patient-centered outcomes. So by abolishing respiratory efforts in order to reduce lung distending pressure and minimize ventilator-induced lung injury, we might be incurring in this diaphragm disuse atrophy and also worsening patient outcomes. And the obvious solution to this, which would be allowing respiratory efforts, will take us again on this very vicious or negative cycle of increasing lung distending pressure and even maybe generating load-induced diaphragm injury. So as Dr. Ferguson just mentioned, we are not sure what to do in terms of how to limit this, in terms of what interventions or even what physiological limits for this we should apply. But we do have some physiological background to help us kind of like start monitoring and then start making decisions. So we're worried about lung distending pressure and magnitude of respiratory effort. But when we measure plateau pressure, which we use as a surrogate of alveolar pressure, we're basically measuring the distending pressure to inflate the lungs and also the chest wall without considering the magnitude of effort, basically. And the magnitude of effort will be important because the pleural pressure, which will give us an idea of how much what the magnitude of the respiratory effort is in a patient who's breathing spontaneously, is not often measured in regular critical care. So what can we do? Well, I think that the number one or the most used strategy in terms of invasive monitoring will be to place an esophageal catheter, which is basically just like something similar to a nasogastric tube that goes into the esophagus and has a balloon that sits at the bottom third of the esophagus. And at this position, this balloon transduces pressure from the esophagus, which are fairly similar to the pleural pressure, and we can use this as a surrogate of pleural pressure and give us an idea of what the magnitude of the respiratory effort is. Also, just by calculating the gradient between the alveolar pressure, the plateau pressure, and the esophageal pressure, the pleural pressure, we can get an idea of the transpulmonary pressure during that breath, giving us an idea of how much pressure is spent to inflate the lung as a consequence of the pressure applied by the ventilator and the pressure generated by the patient's own breathing efforts. So this is a patient who's being ventilated on a pressure control mode, and they have an esophageal balloon inside them. And right from the get-go, we see the flow and airway waveforms, which we're used to seeing in every patient who's ventilated. But again, here we have the esophageal pressure, which is negative because the patient is making spontaneous breathing efforts, and the transpulmonary pressure, which just results from the subtraction of the airway pressure minus, or plus, actually, the esophageal pressure, which is negative, and that results in a, in a sum, right? So right from the get-go, we get the idea that the airway dynamic driving pressure, say, the difference between peak pressure and PEEP, the one that we often use to evaluate the risk of injurious ventilation due to excessive lung distension, actually underestimates the actual driving lung distending pressure, the transpulmonary distending pressure. And that's because, again, as mentioned previously, this airway pressure doesn't consider the magnitude of the respiratory effort. So placing an esophageal balloon on a patient gives us these two very important pieces of information. It gives us the magnitude of the respiratory effort, which again we can associate to the risk of diaphragm disuse atrophy when it's very small, and to potentially load-induced diaphragm injury when it's very high, and possibly more importantly, it gives us an idea of what the actual lung distending pressure is during a spontaneous breath. A small caveat or note here, as you'll know that I'm talking about the dynamic driving pressure, which is not something that we're often used to measure in patients because we consider the risk of lung injury is explained by the static lung distending pressure, so we use plateau pressure, and this has the added benefit that it doesn't consider the resistive component of the mechanical breath, and because we think that the resistive component might not be, let's say, as important as the static component, the plateau pressure or the driving static pressure is more appropriate. But you could argue that during spontaneous mechanical ventilation, it's actually the peak pressure, so the dynamic driving pressure, the one that you care about, and there's not a whole bunch of evidence about this, but this very elegant study by Takeshi Yoshida kind of points to this. So this is an experiment with animals with induced peaks, induced ARDS, which were first subjected to controlled mechanical ventilation and then allowed to breathe spontaneously. So on this side, at this time, these animals were paralyzed. And an EIT belt was placed to measure regional lung stretch in the non-dependent and in the dependent areas of the lung. So while being paralyzed, you can see that the maximum lung stretch, both in the non-dependent and dependent areas, coincides with the plateau pressure at the end of the inspiratory hold, which is what basically we do on everyday basis on patients receiving controlled mechanical ventilation. On the other hand, when animals were allowed to breathe spontaneously, you can note two different things. First, the maximum point of lung stretch is different between the dependent and the non-dependent. The dependent, the regional lung stretch is maximal at the beginning, and on the non-dependent areas, the lung stretch is maximal at the end. And incidentally, this maximum lung stretch at the beginning of the breath coincides not with the plateau pressure, but with the peak pressure, suggesting that during spontaneous ventilation, the area of the lung that could a priori be thought to be more at risk, the dependent areas of the lung, are actually more stretched during the peak pressure situation, say, where the maximum amount of effort is being made, and not so much the plateau pressure. And this could bring some rationale as to why to measure the dynamic transponder pressure instead. You can do some other more maybe fancy measurements with esophageal balloon as well, and you can quantify the work of breathing. This is not directly related to the lung distending pressure, but it does give us an idea of how the work of breathing can be divided and which specific component of, let's say, resistance to airway entry, to volume entry into the lungs is dissipated, or how much pressure is applied to overcome each of these components. And this is what's called a Campbell diagram, which you can derive using some specific software or just making some extra math, not at the bedside, but probably you need some offline analysis, where you'll calculate the chest wall compliance, which you can estimate or actually measure if you could measure the patient's conditions under paralysis, and the compliance of the lung, and this being FRC, the point where both lines intercept. You trace a PV loop, basically, which has inspiration and expiration, and with that you can actually separate the resistive component, the one that appears when there is an active breath, when pressure is being spent to overcome this resistive component to get volume into the lung. And then you can actually separate it from the elastic component, give you an idea of how much pressure is spent to overcome each of these components. And you can use this in patients who have sound pathology, as this is a schematic example. But here, for instance, you have a situation where you change the pressure, but you don't gain any volume, and this is above FRC, so this could be indicative of intrinsic PEEP. So that's the pressure that the patient needs to generate to overcome intrinsic PEEP. Then you have, again, the same resistive component, the elastic component, and you can even, if the patient is making, say, expiratory efforts as well, you can see that there's pressure being generated farther away from the chest wall compliance situation, basically. And again, you can divide these components into resistive, elastic, intrinsic PEEP, and the expiratory effort part, say. So this is more fancy a little bit. You probably need some extra software to do it, but it's also something that you can do when you place an esophageal balloon to measure. So this is not the end. We have non-invasive tools, fortunately, because not every center has access to esophageal balloons, and although it's not super invasive because it's not different than an NG tube. Probably it's not something that we do every day, and you do need to have some sort of expertise on how to use it. There are some caveats to how you inflate the balloon, position the balloon, etc. Some non-invasive tools have been generated or designed to actually measure this without the need of extra equipment. So here we have some examples, which I'll freeze right now. So the first, probably the most well-known, is the P0.1, which represents the pressure in the airway in the first 100 milliseconds since the breath was initiated. So this is considered a surrogate of the respiratory drive, basically because the patient is sort of not aware that this pressure is being measured because the occlusion is so small, so short, I should say, that the patient is not aware. And it has the downside, say, compared to the other ones that we'll see, that doesn't actually give you an idea of the actual magnitude of the respiratory effort, nor the magnitude of the transpulmonary pressure being generated. We'll see some data that has validated this in terms of thresholds for respiratory effort, but it doesn't give you the exact number. More recent, I wouldn't say discovery, maybe the word is publication, yeah, has showed that POCC or POC, there's no good way to abbreviate this, or the occlusion pressure after an end expiratory hold, can also be used as a surrogate of respiratory effort. This one has the benefit that it will give you the actual magnitude of the respiratory effort, so you can get an actual number, and you can transduce that to the magnitude of the transpulmonary pressure with some correction factors, which I'll discuss just in a second. Just know that when you do the hold here, the effort measured with the esophageal manometry here is quite different than the ones done before, so it's not like this number is similar to that one, but it needs to be corrected. And finally, the other thing you can do is do an end inspiratory hold. This you can't do in all of the patients because sometimes this is not as steady. Actually, this one's not as stable, but you could argue that that's a heartbeat over there, but you would like probably more stability there in that line. And this has also been suggested to as a surrogate of the magnitude of the respiratory effort that you could use at the bedside non-invasively. So I'm just going to skim through the next ones because it's pretty much what I've just been discussing about. For POCC, just to get an idea of what the actual esophageal pressure swing is, you will need to correct it for some correction factors derived in the study that validated this number. So you have to multiply it by either 0.75 if you want to get the predicted P mass or the magnitude of the effort, or you'll have to multiply it by 0.66 after adding the dynamic driving pressure to get an idea of what the transpulmonary dynamic driving pressure is. And this is fairly good to detect low and high effort when using different thresholds. As you see, all these ROC curves have an area under the curve above 0.9, so they're fairly good. Not so good to use in terms of like exchangeability, so agreement is not so good. There's some difference up to even, let's say, I wouldn't say average, but around 5 to 10 centimeters of water, which can be a lot when talking about these numbers, so not so good there. P0.1, as I mentioned, is a measure, let's say, just of effort because it doesn't quantify the descending pressure, but it can also be used using different thresholds as a surrogate of low effort, for which is very, very good, and for high effort, for which its performance is maybe a little bit less, not as good. And finally, for PMI, it has shown to have a very good correlation with the esophageal pressure swing. So in terms of the numbers, tracking the numbers, it's fairly good. We don't have a lot of data on agreements on this, but it's fairly good. And also, I should say, it correlates very good with the numbers derived from POCC. As I mentioned before, the POCC-derived numbers use a dynamic maneuver, whereas the PMI uses a static maneuver. So while the correlation is good, the numbers, maybe here the slope is not as similar to the one to the other, but in this study they actually added that kind of like resistive component for which they could measure in some of the patients, and you can see that when you add the resistive component to the POCC-derived variables, the line does get closer to identity and the correlation does improve, suggesting that both numbers are actually explicative of the same phenomenon and they could be used to evaluate lung distending pressure. And effort, I should say. So just to wrap it up, because I'm a little bit over time, Monitoring of effort and lung distending pressure is important to determine the risk of lung and diaphragm injury. The main issue here is that, unfortunately, we still don't have good numbers in terms of what these limits should be. But there are a number of invasive, as I mentioned, with the esophageal balloon, but also non-invasive tools that can be used to accurately detect insufficient excessive efforts and lung distending pressures, and that can hopefully be used for more pragmatic approaches, as Dr. Brochard mentioned, in terms of how to study this in the future. So thank you very much, and yeah, I'm open for questions.
Thank you very much, Jose. We have time for questions. So for people who would like to use it doing this simple pause at an expiration or an inspiration, are there situations where it's not recommended or where it would not work? Do you have any tips to propose?
Well, yeah, so I would say that for P0.1, which some ventilators actually displayed live on the screen, whereas others ask for a maneuver, and POCC, there's no major, let's say, caveats in terms of doing the measurement. For POCC, I would say it is sort of important that the patient's not aware that you're doing the measurement, because they might react differently and they might generate more larger respiratory effort. Actually, that happens when they feel that the occlusion is happening, but if they are aware that this is going on, they might respond differently. And for PMI, I think that's the trickiest one, if that's a word. The maneuver has been shown in different series that it is reliable in up to, let's say, 3/4, 80% of the patients, but there's a fairly large number, 20%, 25% of patients in which you can do it. This is mostly patients who are not relaxing their respiratory muscles while doing the hold, and that can lead to an unstable plateau. As I mentioned before, it could be going up or even if there's a lot of effort going down. But in those cases, you should disregard that number there in terms of using to titrate whatever intervention you're using. So I would say that's the main caveat there with those non-invasive ones.
Okay.
Hi.
Thank you very much, Jose.
But it's not this one.
No,
Okay.
Okay.
Okay. So let's move forward, and I'd like to invite Professor Roca from Barcelona, Spain. And today we'll talk about detecting muscle fatigue using surface electromyography. Professor Roca?
Thank you very much. It's my pleasure to be here. These are my disclosures. One of them should be partially related with the talk, because we are working with a company that is developing devices to prevent muscle atrophy in critically ill patients. Well, what is muscle fatigue? We could agree that maybe we could define it as the decline in the ability of a muscle to generate a force, right? Which is something that happens quite frequently in the ICU after a vigorous exercise, maybe when patients are treated with high flow, and we could not recognize that they are doing a huge effort. Maybe after prolonged muscle disuse, prolonged sedation, or whatever, or maybe when the patient had some kind of neuromuscular disease. And the way to measure the pressure is, as Jose said before, is placing an esophageal balloon, which I can swear it's not so comfortable, especially in patients who are not intubated or those who are awake. Every time you try to swallow and you have the catheter inside your stomach, it seems that it is the end of the world. Even though you have Iwan Golliger at your side, which is a highly experienced doctor and a very experienced nurse taking care of you, I can assure you that it's not an easy work to maintain during days and days in order to take a decision at the bedside. So this makes us to explore alternatives. And because we all agree that muscle weakness is something that has importance in terms of prognosis of our patients. And this is a paper by Ewan that was published some years ago in the Blue Journal that shows that those patients who maintain the diaphragm thickness over time during the ICU evolution had a better prognosis. So weakness might be associated with worse outcomes, right? So we have the problem, and now we need to look for alternatives. And one alternative could be the surface EMG. I like it because it's non-invasive. And everything that it's non-invasive, it's usually more complicated to interpret, but it's much more very easier to use for the healthcare workers and much more accepted by the patient. And the other advantage is that you can measure not only the diaphragm effort, but also the contribution of other muscles to the inspiratory effort, which are the parasternal, sternocleidomastoid, abdominal muscles, escalene, and other even expiratory muscles that I think that Leo will address this in the following lecture. One of the limitations that we will discuss is that it's not so easy to place the electrode. That the electrode is the same that you use for the electrocardiogram, but according to your anthropometric measure, the place that you have to put the electrode might not be the same. And maybe ultrasound could help us to select the best position for each muscle. However, it's not an easy thing. And the other point is that in the left side is the data that you have, the raw data, and you need to filter them to have something that you can read more easily at the bedside. And sometimes it requires an offline analysis. Moreover, we need to normalize the values because probably a trumpetist could make a bigger effort than me because his muscles are trained to make a huge effort to play the trumpet. So it can be done by using a maximal voluntary inspiratory maneuver that improves comparability and interpretability of the results. And easily we could say that maybe the amplitude or the area under the curve of this filtered data reflects the intensity of the muscle activation. But the main issue is, well, it could be relatively easy collected, but it really correlates with effort. And we have some data. This is a couple of works. The first one is from the group of Giacomo Vellani. What they tried is to compare the standard method by using esophageal balloon with another method using surface EMG, and by using by applying an expiratory hold, they measure the swing in the airway pressure, and they define this PEY index that could be used to estimate the PMASC assessed measure or assessed, calculated, better said, by using surface EMG. And the correlation was pretty good in this study, but it could be even improved. And in other studies, a group from Netherlands showed that in different levels of pressure support, the pressure time product measured by esophageal balloon decreased by increasing pressure support, which is the same that happens with the pressure time product measure using surface EMG. So it seems that it could be at some point correlated, and we can improve this correlation if we take into account the neuromechanical efficiency index, which is the relation between how much pressure I have according to the activity, related to the activity. The only issue is that this index may vary from the same patient from one day to another according to the status of the patient. However, if you look to the Bland-Allman analysis and you try to estimate the PTP by using surface EMG compared with the PTP using esophageal balloon, when you include this this index, the prediction of the PMAS improves a bit. So it makes sense to consider when you are improving. Of course, this is an offline analysis, and we are far away from being able to implement it in the routine clinical practice. What are the potential clinical applications that we can use EMG in our ICUs? This is a study from the group of Giacomo Bellani again, where they perform surface EMG during SBT trials, long SBT trials. As you can see, the SBT trials takes up to 2 hours, which I'm not sure that is not currently the standard of care, and makes me to be a little bit more skeptic in terms of the results that they obtain, because as you can see, during the first time of the SBT, during the first 30 minutes, it looks like the diaphragm starts to being separated by not so separated as after 2 hours. And similar happens with the accessory muscles when the SBT was performed. So we were thinking about how to improve the analysis, and we decided to apply this kind of joint analysis of spectrum and amplitude. Amplitude is what we were talking about, the area under the curve, the root mean square, let's call it in this way. It increases when the force increases, but it increases also as a response of fatigue. It's the early sign of fatigue, because if you want to maintain the same pressure that you are doing and you need to increase the amplitude, it means that the muscles are doing more effort to maintain the same pressure. And if you take this into account and you add the frequency in the equation, you would see that when the frequency goes down and the amplitude goes up, it should be related with fatigue. By contrast, when the amplitude goes up and the frequency goes up as well, it means that the force is increasing. So if we have this quadrant and we make sequential measurements during SBT trials, during non-invasive respiratory support, during the transition phase of mechanical ventilation, maybe we could assess earlier when the patient is at risk of muscle fatigue and provide any kind of early intervention that the patient needs. And we first performed a very short proof of concept study, including healthy volunteers, that we asked them to breathe through this device that allows us to increase the respiratory resistance, creating some kind of fatigue. This is the data that we observe. The clearer the point, the longer the period. So this is the starting point of the left diaphragm, in the baseline measurements that takes 10 minutes, and then it starts the fatigue, and then this is the recuperation period. So if we have to place a line, this is what happens over time in the left diaphragm and in the right diaphragm. So we bring them to fatigue, and then we let them to start recover. Of course, we make 10 minutes measurements. So we expect that if we prolong the measurement, at the end they will be back again to the baseline position, right? So it seems that these longitudinal measurements could be useful in terms of detecting trends which allow us to be more active earlier during the journey of the patient in the ICU. And then we move to the next step was SBT. And unfortunately, I cannot show you the results because we are in the inclusion period. We have included 17 patients, 10 of them successed the SBT, 2 of them failed during SBT trial, and 5 of them required brain intubation after extubation. So we did not detect any clinical variable to do not extubate them, but even do that, they develop some kind of problem after extubation that make us to reintubate them. I hope that I will be able to present data very soon. There are a lot of limitations, and this is almost my last slide, that we have to take into account when applying this technology. The first thing is, where do we place the electrode? There are a lot of interference and artifacts, so we have to filter the signal. This leads to some kind of offline data processing. The patient's variability is something that it's common almost in all the problems that we have in the ICU. Of course, the obese patients is much more difficult to obtain a reliable signal, and the short time measurements, because these prolonged measurements are still not available due to technical limitations, and we have no clear definition of when start and when finish the signal of EMG, because muscle activation is like an on and off. There are a lot of fibers that start contracting and stop contracting at different time points. However, I think that EMG could be a promising tool for monitoring ICU patients that may allow us for earlier interventions, especially in very delicate situations, such as identifying those patients who are going to fail on non-invasive respiratory support. But we have to overcome several technical limitations before implementing them in routine clinical practice. Thank you very much, and I will be happy to take any questions.
Oh, over there.
Hello.
Hi, Oriol. Thank you. Hi. This is really great presentation. I have learned that fatigue is a decline in force that is reversible after rest. Do you really think that, is there any evidence that an ICU patient can ever develop fatigue of the respiratory muscles? And I think even 15 or 20 years ago, Martin Tobin published in the Blue Journal that actually if patients fail a spontaneous breathing trial, there's no evidence of fatigue. He looked at magnetic stimulation of the phrenic nerves before and after the SBT. So I know you had a very difficult title to talk about fatigue, but do you agree with me that fatigue does not develop in ICU patients of the respiratory muscles?
Yeah.
Thank you.
I know that you were going to ask, Leo. I was really convinced about that. No, the issue of focusing on SBT is because it's the next step of our proof of concept. I agree with you that fatigue during weaning, I mean, the main cause of weaning failure might be others, but it was a test of proving how the technique works in the ICU settings. My main point is, or where I really want to test it, is during non-invasive respiratory support. This, I think, that really plays a role in terms of, detecting early those patients who are not able to interrupt the vicious circle of patient self-inflicted lung injury. This is the end of the road, and this is where we want to arrive. But before that, the non-invasive, the non-intubated patient is probably the most difficult to address. So we wanted to test, even though we know that the results might not be good, but we want to be familiar with the technique before going to the non-intubated patients.
But I think the same is true, but we're not going to discuss it too long. But I think even in the non-intubated patients, it's really difficult to generate fatigue of the respiratory muscles.
Yeah, but I think that, to be honest, I think that patients are a little bit confused about what they express, like dyspnea, fatigue, comfort, and all these kind of things. And I'm not sure that every time that they say that they are, I had a lot of patients that say, I'm tired, I don't want to breathe anymore. I don't know what this tired means, because we clearly know what dyspnea means for us, but the patient does not have the medical knowledge to differentiate between dyspnea, fatigue, or other. But it's only an opinion, eh? We will see.
Yeah, Oriol, I think you should get away from the word fatigue and just say excessive muscle load.
Yeah.
Because you know that some patients with this excessive muscle load, they will stop breathing without any muscle fatigue, and it's called central fatigue. So,
yeah.
But I think your tool is really interesting. But you just showed one slide with nice tracing. So my question was about the practical aspect of, sometimes it's very noisy and you have difficulties to get something, you know, a baseline. So what's your experience with that?
Yeah, behind that nice plots that I show you at the end.
Which we call the representative patient,
exactly.
Usually, right?
There is a lot of work behind of filtering the signal. And there are a lot of hours of engineers working on how to filter the signal. Now we have we have improved the technique on how we acquire the data and how we process and envelope the data to get these plots. And then our aim is to, because of course there is variability in between patients, so we need to have enough patients to be sure that the behavior of 70% or 60% is the one that I have shown you.
Excellent. I have one question. Because I am a person that works with biomarkers, and we have a paper ongoing, and we observe it because we are also working with fatigue. And we work with some scales, some clinical scales that have been performed at the bedside, as well as the two important markers called irisin and myostatin. Do you think that these biomarkers, that there are several papers showing that this is very well correlated with the fatigue, is a good option to be analyzed comparing, for instance, with this technique? Because I am an old person, so I remember the old invasive electromyography, and and I remember that we have several difficulties in the past. But now we are working with these biomarkers and trying to compare, and to evaluate with fatigue. What do you think about that?
I think that every physiological study should be accompanied with some biological marker that supports the data that you are showing, and in the other way around as well. And biological studies should be accompanied by physiological variables that make the match the perfect match.
Yeah.
So which one is this biomarker? Honestly, I don't know. But if you have any suggestion, we will address it.
I see we have a question. If you can make it short and short
Sure.
response.
Martín Angulo from Uruguay. You know, diaphragm dysfunction can be a result of a neurological component, a myo component, or a combination of both. Do you think that electromyography combined with the newer techniques like speckle tracking or tisular Doppler ultrasound can help us to detect different phenotypes?
Yeah, there is a paper recently published in Critical Care that combines the POC with EDI to assess the neuromuscular coupling. So it's something that it's currently being working on, and for sure it could improve the data that we have until now.
Thanks.
Thank you very much.
Thank you.
Thank you. It's my pleasure to introduce Professor Rinaldo Bellomo, coming from Melbourne, Australia, to talk about P0.1 and Pocc during pressure support ventilation.
Thank you very much, Laurent. Invasive pressure support ventilation appears to be very common, certainly is very common in Australia, particularly sustained pressure support ventilation. However, if you look at the literature, there's very limited data on the epidemiology of pressure support ventilation in patients that are invasively ventilated for up to a week or so. We conducted a study in a group of patients who were ventilated for more than 1 week. It's a multi-centric study of almost 150 such patients. And we identified, you can see that in green, the pressure support ventilation occupies about 40% of all the mechanical ventilation time. So it's a big deal. And despite it being a big deal, there is limited work compared to mandatory ventilation. Leo, who's here, has done some work to assess occlusion maneuvers and their ability to predict or associate with invasive maneuvers that might define the amount of effort as well as drive from the point of view of respiration in spontaneously ventilated patients. You can see a graphic display of these variables. I just draw to your attention to the fact that in this population of patients, the assessment of the work, of the effort, and the assessment of drive was pretty good non-invasively compared to invasive methodology. So that provides us with some degree of reassurance that using these techniques at the patient's bedside can then provide us a substantial amount of epidemiologic understanding of what might be happening to respiratory drive and respiratory effort in people receiving spontaneous ventilation with pressure support. So you've seen already these graphic representations of what it is that we're looking at. P.1 is the deflection in the first 0.1 of a second. The Pocc is the deflection during expiration to the maximum level, and PMI is the difference between the plateau pressure and the peak pressure during an inspiratory hold during spontaneous ventilation. So what do we know about these in terms of the epidemiology and our understanding? There are limited studies of what happens if you increase pressure support ventilation in these patients, and you can see there is clearly a decrease in the occlusion pressure and the P.1. We got some understanding what kind of factors might influence respiratory drive. We got limited data on what might influence respiratory effort at a clinical level. So we aim to conduct studies to evaluate what the effect of change in pressure support would be on these measures of drive and effort, to evaluate the correlation between these measures and the associated factors that might be associated with changes in pressure support and absolute values. This is a multi-center study. It's a physiological study in 4 large hospitals. We took patients that were on pressure support ventilation and expected to be on pressure support ventilation for more than 24 hours and excluded patients with neuromuscular disease or excessive sedation. We visited the patients twice a day. We collected information on their baseline respiratory characteristics on the ventilator. We performed pressure support measurements at 5, 10, or 15 of pressure support in random order so that we would not have the effect of time on these measurements. We collected information on P0.1, Pocc, and of course P plateau. 3 measurements, worked out the median with the patient in a stable condition, and we obtained other information about the patients. We categorized these values for analysis into low, moderate, and high for these 3 characteristics, and we performed statistical assessment of our observations. So these are 4 hospitals that participated in the study. We had 94 patients for about 300 assessment and about 1,000 measurements. This is the patient population, males mostly with typical diseases that lead to prolonged mechanical ventilation, and the cause of respiratory failure similar to what you would expect across the board in a heterogeneous population. Most of them had endotracheal intubation. Only 3 patients had a tracheostomy tube during the assessment, and this gives you a sense of the outcome of the patients and the timing of our assessment. So the baseline characteristics from a ventilatory point of view in these patients, they're typical on the stereotypical pressure support ventilation that we see in our country, which is 10 of pressure support and 5 of PEEP, with 6 there. So it's the typical stuff that we see. You can see these people were not on high levels of oxygenation. Their tidal volume was moderate. The respiratory rate was moderate. The minute ventilation was moderate. This is typical patients on pressure support ventilation in our country. You can see the plateau pressure and the dynamic compliance there. You can see that oxygenation was not a big problem and that these patients were relatively stable. Their sedation was mild to moderate with a RASS of -2, but all of these patients had a degree of sedation in the form of propofol or fentanyl or dexmedetomidine to allow mechanical ventilation and its tolerance. So when we change pressure support ventilation in a random order and we compare the tidal volume with 5, 10, or 15 of pressure support, you can see there is a significant change in the tidal volume from 5 to 15. The respiratory rate goes down from 20 to 14, and the minute ventilation is slightly affected and it increases. The peak pressure, as you would expect, and the plateau pressure go up, and obviously compliance doesn't change. You can see that most of our patients had a P0.1 in a near normal range, with only a quarter or so of the patients with an elevated P0.1, and you can see that the P0.1, which is the respiratory drive, is suppressed by 15 of pressure support and possibly suppressed even with 10 of pressure support. The occlusion pressure generated by patients, and again, is moderate, and then it is suppressed up to 10 or 15 of pressure support, and PMI is consistent with that. And this is a graphic representation divided into those with a low drive, a moderate drive, and a high drive. You can see that the effects are similar, but of course it's steeper if you've got a high drive and a high effort that is being addressed by changes in pressure support levels. These measures are to a degree correlated. It's not surprising. The respiratory drive should be correlated with respiratory effort. But PMI is harder to measure, and it is not nearly as reproducible and reliable as Pocc in our experience, and I think that's what the literature supports. So its correlation with Pocc and P0.1 is less robust. What are the factors that are associated with the change in P0.1 if you apply a greater level of pressure support? Well, these are the things you would expect: the PCO2, the pH, the lactate, the respiratory rate, the minute ventilation. So that kind of half validates that this is a reasonable assessment of pressure support effects on respiratory drive. What about on linear modeling, what are the factors that are independently associated with the P0.1. Obviously, the pressure support level is dominant. pH remains a factor. And the dose of morphine equivalent in the sedation also remains a factor. For P0.c, it's again the PCO2, a pH as you would expect, but also the degree of sedation, which is also true of PMI. So all these factors are influencing the respiratory drive and the respiratory effort as you would expect. Now, some things became clear to us as we started looking at these patients, their epidemiology, and one of the things that you would expect, and indeed is true, is that if you got a high respiratory drive, at 28 days follow-up, you're less likely to be alive and ventilator-free. And so this is a nice marker from a prognostic point of view. And this is also true of P0.c. So your ventilatory effort, your respiratory effort, and your respiratory drive are predictors of your outcome from the point of view of ventilator days alive and free. What about responsiveness to the intervention divided by the median? So your response of P0.1 to increasing pressure support is also a predictor of mortality. So if I increase your pressure support and you don't decrease the pressure, the P0.1, then you have a significant risk of dying, which is greater than if you have a response to increasing pressure support. This does not appear to be a signal that we were able to see with respiratory effort, suggesting that they may represent two different biological states in our patients. So in conclusion, we conducted a prospective study in patients receiving extended pressure support ventilation. Our aim was to assess the effect of changing pressure support levels on markers of respiratory drive and markers of respiratory effort. As you would expect, increasing pressure support increased tidal volume, minimum ventilation, plateau pressure and peak pressure, and decreased respiratory rate. It also, as you would expect, decreased the P0.1 and P0.c and PMI, and you were able to see the quantification on average of such effects. We were able to identify factors that are associated with these markers of effort and drive. And now we are focusing on the outcome predictiveness of these changes and responsiveness to identify patients at high risk, where randomization into a trial where pressure support is dedicated to the maintenance of a near physiological P0.1 and near physiological P0.c might be able to modify the course of the clinical outcome compared to usual care. Thank you very much.
Thank you very much. Very original, interesting data. Question here? Wait for it.
Hi, thank you, Dr. Bellomo. Very interesting and I think needed study. Did you also compute the estimated lung-distending pressure using POCC and?
We can calculate it, but we didn't look at it specifically yet. There's a whole lot of that. There's driving pressure, power, there's lots of stuff that we need to go through. This is the first output. We haven't published it yet. We haven't even submitted it. It's just fresh off the statistical analysis of the first tranche of what we want to look at, so I can't answer that, sorry.
Okay, cool.
Jose, I was expecting that you would ask the question about sedation, because Jose Dianti published a paper where he showed there is a very strong interaction between the responsiveness, with what you called, and which I find interesting, and the level of sedation, with much less responsiveness when... so I was wondering whether the lack of responsiveness, which was associated with a bad outcome, was maybe caused by more sedation.
So we have to do a multivariable model. There was a Kaplan-Meier curve, so we didn't do a Cox model, so you're absolutely right. That's a significant comment. But I must also say we selected a particular group of patients. So during pressure support ventilation, the average RASS was -2. If they were below -3, they were excluded. So it's a particular kind of adjusted group of people on pressure support ventilation with a relatively mild degree of sedation on the RAS score. So we may not be able to see the sort of stuff you published, but maybe we will. We'll just have to go and have a look.
And I know there is nothing special in your cohort, but is this the way modern ventilation is done? All patients and pressure support have to be sedated, so I'm just...
So, yeah, it's a very good comment, and, you know, this is the practice in 4 different hospitals in the city of Melbourne, a very venerable city in Australia. I don't know what goes on everywhere else because no one's telling us. No one's publishing it. No one's telling us. So it's a secret. I don't know what's going on in Canada. Maybe in Canada they're all really good, polite, and they do the right thing and decrease sedation. Everybody's happy. Maybe in Argentina everything is fantastic, and it's only the Australian doctors that are crazy. I don't know.
Yeah, no, I'm not saying there is anything special with your cohort, but I'm just saying in general, because I think we see that very often. Do we really need to give sedation to these patients?
I don't. Possibly not. I don't know. Yeah.
But what about the type of sedation? We talk about the...
You mentioned,
yeah.
So you saw these people on average were on 100 of propofol, and on average were on 50 of fentanyl, and many of them were on dexmedetomidine. And, you know, you just have to consider that there are all different situations. Some of them might have been delirious. Some of them might have been agitated. Some of them there must have been some kind of clinical reasons for those decisions. And I can't really comment whether they're wise or not, but I don't think people would apply that degree of sedation unless they felt it was appropriate. But of course, sedation is such a field of opinion and judgment at the bedside, which is incredibly difficult to study.
Yeah, I fully agree with you.
Okay, thanks so much.
No worries.
Thank you. So now I have an honor to introduce Professor Leo Heunks from Netherlands. Is Leo here? Yes.
Yep.
He will talk today about the electrostimulation to preserve expiratory muscle function. Leo?
Thank you very much, Patricia. It's really a pleasure and honor to present here today about the electrical stimulation of the expiratory muscles. So these are my disclosures, and what's important that we got research grants and consultancy from Liberate Medical, equipment that I'm going to discuss later on. So let us first review the anatomy of the expiratory muscles, because I think that's important for now. The most important muscles for expiration are the lateral abdominal wall muscles. These are the transverse abdominis, internal oblique, and external oblique. And the rectus abdominis is, in most people, not really a muscle for expiration. You can imagine only if you are obese, contraction of the rectus abdominis will increase intra-abdominal pressure, but if you're not obese, it will not. There's some other muscles that play a role during expiration, the internal intercostal muscles, the sternocleidomastoid muscles that stabilize the chest wall. And as you're sitting here in this room, expiration is largely passive, and your expiratory muscles are not active, or there's only a little bit of tonic activity to maintain position of the trunk. But let us look at this patient. So this was a patient some time ago in the ICU. We were just rounding, and this patient is in the weaning phase. And if you look closely, what you will see, now the patient stops breathing for a second, but in a moment you'll see that there is, right here, active contraction of the abdominal wall muscles. And the interesting question was, why is this patient doing this? Because expiration should be largely passive, right? So there's 3 reasons why patients can use, or you can use, the expiratory muscles just during breathing. And the first is when inspiratory load increases. So if you go out running, you're exercising, you will use the expiratory muscles, recruit expiratory muscles, but also in patients weaning from mechanical ventilation, patients with high metabolic load, for instance for sepsis, will recruit expiratory muscles. But also with severe weakness of the inspiratory muscles, expiratory muscles will be recruited. So when there is a disbalance between inspiratory capacity and the load imposed on the inspiratory muscles, expiratory muscles will be recruited. And finally, with increased end-expiratory lung volume, pulmonary hyperinflation, you will recruit the expiratory muscles as well. So what are the physiological effects of recruiting the expiratory muscles? Well, first, recruitment of the lateral abdominal wall muscles increases abdominal pressure. This results in a more cranial position of the diaphragm. So at the end, at the beginning of inspiration, there's a more cranial position of the diaphragm, which makes the muscle more efficient in generating inspiration. So in this way, the expiratory muscles can facilitate inspiratory muscle efficiency. Secondly, the increase in abdominal pressure will increase expiratory flow. With higher expiratory flow, and expiratory lung volume is lower, and this happens. So recruiting the expiratory muscles, you really have a low end expiratory lung volume. So only if you release the expiratory muscles, inspiration starts. So this is a very smart way of the body to facilitate inspiration. And thirdly, the increase in abdominal pressure will increase pleural pressure, will decrease transpulmonary pressure, and reduces lung strain. And I realize this may be rather complex physiology. We summarized that in this paper, but this is a little bit more just a general overview. And of course, the expiratory muscles play a very important role in coughing, maintaining airway clearance, preventing atelectasis. So having said that, it is important to review the effects of mechanical ventilation, of critical illness on the expiratory muscles. And unfortunately, there's a very limited number of studies that evaluated function or the impact of critical illness on the expiratory muscles. There's much more data for the inspiratory muscles, actually. So this is a study we did a couple of years ago from Hua Xi from China when he visited our lab. It's an observational cohort study in patients that were expected to be on the ventilator for more than 3 days. And what she did is performed ultrasound of the diaphragm and the expiratory muscles on a daily basis. And right here you see the change in thickness of the expiratory muscles while the patients were on the ventilator. And as you can see right here, in 64% of the patients, thickness remained more or less stable. In 22% of the patient, thickness increased. And in 22% of the patients, thickness of the expiratory muscles decreased as assessed with ultrasound. And the interesting thing is that there is an association between loss in expiratory muscle mass and the hospital length of stay. And I think this is intriguing as well, because we did not find any correlation between changes in thickness of the diaphragm and changes in thickness of the expiratory muscles. So maybe the diaphragm decreases in thickness, while the expiratory muscles increase in thickness, or the other way around. So this is an interesting observation, and I do not have a very good explanation, actually. This is an important study from the group of Ewan Gallagher and Nia Schreiber. And what they aim to investigate whether thickening fraction of the expiratory muscles during coughing in patients on invasive ventilator is associated with the probability of successful ventilator liberation in patients successfully passing an SBT. So what they did, they made patients cough, either ask, and if they could not ask it, they just inserted a suction catheter and measured thickening fraction of the expiratory muscles during coughing. So right here, this is a group of healthy subjects. This is in patients that were successfully extubated. And this is in patients that were not successfully liberated from the ventilator. And the interesting thing is, if your thickening fraction is higher than, in this case, 127%, only one of the patients failed extubation. I think that's a very interesting observation. And if you look right here, the lower the thickening fraction of the expiratory muscles, the higher the likelihood of being re-intubated. And one more study I would like to discuss from Thiel in critical care a couple of years ago. So this was a secondary analysis of 2 trials. Patients at high risk of extubation failure, so age higher than 65 years of age, past medical history of cardiopulmonary disease and some other risk factors, patients on a ventilator for plus minus 7 days, and all patients had a successful spontaneous breathing trial. Again, cough strength was measured with the same method as in the study by Ewan Gallagher. 16% of the patients failed extubation. And as you can see right here, it's a little bit difficult to see for me, but patients that had a, sorry, I have to check for a second what I'm saying. So, bottom line is, patients that had less cough strength were much more likely to fail extubation as compared to patients with normal cough strength. So it appears that, and that's what they show in multivariate analysis, that cough strength, that a low cough strength is associated with extubation failure. So what I've showed so far is that the expiratory muscles are an important component of the respiratory pump. Weakness develops rapidly in these patients, and weakness is associated with extubation failure. So then there's a good rationale to try to improve expiratory muscle strength. And as you all know, same thing for the diaphragm, we don't have drugs to improve strength of the respiratory pump, right? So maybe it is interesting to look at the effect of neuromuscular electrical stimulation of the expiratory muscles. And this is a pilot study we published a couple of years ago. So it's a sham-controlled study. Actually, it's 2 different cohorts, one cohort from Australia, one from our own center. But because the setup was exactly the same, we published the data together. So these were patients that were expected to be on the ventilator for more than 3 days. And electrical stimulation was applied twice daily for 30 minutes. And the primary outcome for this small study was feasibility, safety, and treatment compliance. So this is how it looks like. Patients are on the ventilator. There's surface electrodes here applied to the lateral abdominal wall muscles. And there's an electrical stimulator that acts in synchrony with expiratory flow. So obviously, electrical stimulation is only applied during expiration. Before randomization, we actually checked whether electrical stimulation resulted in thickening of the muscles, because in some patients you cannot stimulate the muscles, in obese patients, but in some other patients as well. So we made sure that if they are in the active group, it did result in contraction of the muscles. Just you can see here, electrical stimulation is highly feasible. The protocol, as we designed it, was highly feasible. 95% of the patients in the sham group and 87% of the patients in the active group. And reasons why sessions could not be completed was because of patient request, they thought it was uncomfortable, or because of a mean arterial pressure higher than 110 millimeters of mercury, which is a safety criterion. But at all, there was no serious adverse event related to study procedures. When we designed the trial, I was actually a little bit worried that in the very early phase, when the patient was still in a septic or pro-inflammatory condition, that activation of the expiratory muscles might elicit an inflammatory response. There's some animal data to support that, but if you look right here, and we checked really a lot of pro- and anti-inflammatory cytokines, there was no difference between groups. Right here, looking at thickness of the expiratory muscles in the sham group and in the active group, you can see there is a significant difference. And honestly speaking, this was a little bit surprising to me. I mean, I would expect, we were hoping for that electrical stimulation would maintain muscle mass, but that it would increase muscle mass is actually a little bit, well, to me, unexpected, but these are the data. And again, for everyone who's doing ultrasound of the diaphragm, this is much more complicated than doing ultrasound of the expiratory muscles. You know, the diaphragm is only 2 millimeters, while the expiratory muscles are 1 centimeter or so. So doing this is much easier. So these data are only, I think, hypothesis generating. Remember, it's only 40 patients. But the data showed that in the active group, extubation success tended to be higher as compared to sham. And also, the duration of ICU length of stay was shorter than, in the active group was shorter as compared to the control group. But again, this is only hypothesis generating in 40 patients, right? So I think this study, conducted in 2 centers, actually showed that this breath-synchronized electrical stimulation of the expiratory muscles is feasible, it's safe, and it may improve expiratory muscle mass as assessed with ultrasound. And this motivated us to conduct this trial. It's actually ongoing, the PREVENT trial, which is more or less the same design as our pilot study. So randomized controlled trial, active intervention versus sham intervention. At this moment, there are 21 sites recruiting, North America, Europe, and Australia. We expect to recruit approximately 280 patients that have been on the ventilator for at least 24 hours and expect a duration of at least 3 days. The primary endpoint of the PREVENT study will be the time from the first stimulation to successful liberation or ICU discharge, whichever comes first, and there's a couple of secondary outcomes, as you can see right here. Again, the study is ongoing, so I can't present any data at this moment, but maybe in a year, 2 years, we will be able to see whether stimulation of the expiratory muscles indeed improves weaning outcome. And honestly speaking, this was a quite difficult trial in our ICU because physiotherapists and myself were quite enthusiastic about the technique. I think I've shown you there is really a good rationale for this, but I think we need to study to be sure at the end that it does make a difference from patient perspective. So this is my last slide. So the expiratory muscles do play an important role in airway clearance to limit the development of atelectasis, but also in alveolar ventilation. And again, remember the patient I started with. If you're rounding in your ICU and the patient is recruiting the expiratory muscles, this is not normal. So I think you should consider why the patient is doing this. Need the patient a little bit more of inspiratory support? Or does the patient require a little bit less of PEEP? So I think it's interesting to discuss that at the bedside. I've shown you that weakness of the expiratory muscles is associated with adverse clinical outcome, in particular reintubation. And I try to convince you that electrical stimulation is feasible. It will improve muscle thickness, but whether it really improves clinical outcome needs to be established in the next few years. And if you are interested in the role of the expiratory muscles, I think, but I'm a little bit biased, I think this is an interesting paper to read because I think in the literature we haven't paid enough attention to the expiratory muscles actually. Thank you very much.
Thank you, Leo. Excellent questions from the audience. Any questions? Okay, go ahead.
Thank you, Leo. It's Martin Dres from Paris, here, just in front of you. Very nice talk. Thank you very much. I have a comment and a question. The comment is regarding the trial you showed on the 40 patients. I have a problem with this trial. Honestly, I don't understand why the thickness increased. And honestly, if it does, it should not be good, right? If we look at the data from Johan Golliger on the diaphragm, both groups, the group of patients with a decreased thickness and the group of patients with an increased thickness for the diaphragm had similar poor prognosis in terms of weaning. So I'm not sure that we should expect as a benefit an increase of thickness. So it's a comment. I don't know if you would have some answers for that.
Come on, I think that it's a very fair comment. But you know, the issue is if you compare the data to the diaphragm, in human study, which is really a great study, but you have to realize the diaphragm is max 2 millimeters in thickness. An increase in 10%, which was the cutoff in their study, would mean an increase in thickness by 0.2 millimeters, right? I think it's much harder to assess as compared, the comment I made, as compared to the expiratory muscles, which may be 1 centimeter in thickness. So again, I agree with you. This is unexpected, the increase in thickness. You could say, I know that you're targeting at that maybe this is inflammation and it's not a good thing for the muscle, but at least we did not find systemic inflammation and we did not find any adverse effects. So you could be worried that the stimulation very early on does result in muscle injury, reduced cuff strength, and a higher risk of reintubation. At least there was no signal at all in the study. But again, I agree, we have to be very careful with that.
Or maybe it's a bias, I don't know.
Yeah, it could be a bias. Well, but it was a blinded study, as good as it can be for this kind of studies with medical technology, but yes.
Thank you. If I may, my question was, do you think that electrical stimulation for expiratory muscle may have an effect on the diaphragm? A good or bad, I don't know, but it could influence the diaphragm activity in any way?
Yeah, that's an excellent question, Martin, and I think you can reason both ways. What is interesting from a physiological perspective is, I mean, we just showed in a paper in the Blue Journal that the diaphragm remains active in the early phase of expiration, right? What's called a breaking of expiration. What could be the case is that if the diaphragm is still active in the early phase of expiration, and now we're going to stimulate the expiratory muscles, that it might actually result in eccentric contractions, or a better word, lengthening activations that might be injurious. These lengthening activations, again, could be beneficial or damaging for the diaphragm. So I think these are very important questions from a physiological perspective. The clinical relevance in the end, we can only find out with the study we are conducting. But I think these are great points, and actually in a sub-study we are evaluating this.
Another question? Yep, please.
Thank you. My name is Mihir Sheth from Oxford University. Great presentation, and what I was interested in was wondering if you think that there will be an effect on other accessory respiratory muscles. So if we were to stimulate other, like the parasternals or upper intercostals, would that also have a benefit in expiration?
That's a great question. Well, you could say idly, in these patients, we should do electrical stimulation of the expiratory muscles, of the diaphragm, of the intercostal muscles, and maybe very important, of muscles for swallowing as well, right? Because I really didn't touch upon that, but if you want to have effective cough, it is not only recruiting your expiratory muscles, but you need your upper airway muscles as well. If I cough, I have to contract the upper airway muscles as well, right? If you can't do that, your cough is still not very efficient. So, I mean, this is a dilemma when you conduct these kind of studies. Do you say, well, I have to stimulate everything, then so it's going to be really complex? Or, and that's what we chose in this study, we say, well, the expiratory muscles are so important to prevent reintubation. I mean, this is where we're going, but it's a great question.
Just 1 minute.
And Leo, is this stimulation painful, and how long are the sessions?
So the sessions are 2 times a day for 30 minutes. And as we saw in the pilot study, so 87% of the sessions could be completed. A few sessions could not be completed because, and it's especially in the end, when patients are awake without sedation on pressure support, that it's uncomfortable. But this is, actually, if you can explain it to the patient, it's mostly not, well, it's not a problem for the patients.
No pain?
No pain. No, definitely not painful. No.
Good.
I mean, you can buy these kind of equipment on Telcel, right? I'm not sure how it's called in your country, but you can see the advertorials on the television all the time about getting a fantastic belly with using this kind of equipment. I mean, it's...
Leo, physiologically speaking, I know how important it is to evaluate the type of contraction of the diaphragm. For instance, if you contract in the middle or in the periphery, you know, the behavior functionally is different.
Right.
Did you analyze, you know, after this kind of stimulation, these diaphragm amplitude, movement, in order to evaluate the morphology?
No, that's not what we did in this study. I'm not too worried about it because although it is like using the surface electrodes, with the stimulation, you're actually depolarizing the nerves, right? So there will be activation of all the expiratory muscles, but that's Martin's work, all the diaphragm if you stimulate the nerves, right? So I'm not worried that you just activate only a part of the muscle.
Yeah. Because it's so common, for instance, in children and in some patients with COPD, that depending on the stimulation, you have a different behavior.
Right, yeah.
Thank you so much.
Thank you, Leo. Excellent.
So the next presentation is from Dr. Paul Elbers from Amsterdam and discussing ultrasound to guide ventilator settings.
Thank you so much for the introduction and also for the invitation. It's absolutely phenomenal to be here, especially in this audience of people that are so illustrious in the respiratory research. I am from Amsterdam UMC, where I lead the Center for Critical Care Computational Intelligence. So you might have heard from the center because we released the Amsterdam UMC database, which is the first freely available European SU database. So you could download that if you want to do your own research. And I also have the academic bias of being the current chair of the ESICM data science section. So before I start, I first want to remind you that today is a very special day, not only because my city of Amsterdam celebrates its 750th birthday, not only because of my favorite soccer team, Ajax, is today celebrating their 125th birthday, but today I am celebrating my birthday at 50 years. So because of my love for intensive care medicine, I've decided to celebrate it with all of you here. Okay, so there's no talk of ultrasound without mentioning Professor Daniel Lichtenstein. I had the good fortune of being taught personally in Paris by him many years ago, and I grew very fond of his sense of humor. So I would advise you to buy his preferably his book in French, because one of his famous remarks is that in case of B-lines, you should draw several blood cultures, so the B-lines will disappear. So, talking about the relevance of his work in terms of setting the ventilator, I think it begins with getting your diagnosis right. So we all know the blue protocol, and this has been adapted many times also by some members of our group to use the linkage between diagnosis and ventilator settings. So for example, if your ultrasound would lead to a diagnosis of pneumothorax, it would be obvious to have a low or no PEEP strategy. So, and you can read on the slide, so the same goes for pulmonary embolus and COPD asthma. For cardiopulmonary edema and pneumonia, should obviously titrate PEEP. But what is not present here, as you can probably recognize being in this session, is ARDS, right? And that is because that's a different ballgame. So our group has also developed a lung ultrasound prediction model, or rather, because I think it's a misnomer, it's a diagnostic model based on ultrasound findings, so a standard 2x6 regional ultrasound assessment in which we combine basic lung ultrasound findings and aeration scores. So they come up to a score of about 18 points per side maximum, and combine that with specific lung ultrasound findings for ARDS to come to the diagnosis of ARDS, which was finally confirmed by a panel of experts and other imaging. And I think this is just the beginning, because our group, and I think many others, are using these well-annotated ultrasound images to put them into a efficient transformer and get the diagnosis automatically, especially separating it from cardiovascular pulmonary edema. And if you know that diagnosis, there is currently a trend, and it's a trend with good reason, to discriminate between focal lung morphology and non-focal lung morphology. And when I say focal lung morphology, what I actually mean is a posterior distribution of your ADS ultrasound and also CT picture versus non-focal, which is basically the rest. So the idea is to recommend a lower PEEP and a strategy of proning for a focal lung morphology if the affected areas are mainly posterior, whereas a higher PEEP and recruitment maneuver could be recommended for a non-focal lung morphology. Now, when I say could be recommended, I mean this is based basically on a non-ultrasound trial called the LIFE study, in which a signal was found in favor of this strategy, although the original analysis couldn't find that, but it turned out that many patients were misclassified. So there's probably a good rationale of adhering to the strategy, and you can determine this difference by ultrasound, although that is also currently being tested in a multi-center trial. So if you have set the PEEP, you might as well use ultrasound to see if you have done this correctly. So this is a very highly cited paper on setting PEEP with ultrasound, and you can see immediately on the left side with zero PEEP areas of consolidation, both in the upper and lower panel, which will either disappear and give you A lines in the right upper panel. Or actually, there's a slight mistake in there, right? Because they're not all A lines, because you see that the distance of those arrows is not equidistant to the first A lines. But at least there are some A lines, and in the right lower corner, you can see a beautiful spray of B lines indicating that there is apposition of the lung. So this PEEP setting actually resulted in recruitment. So what you probably want to avoid is tidal recruitment, at least too much of it. So along the same vein, you could use ultrasound at many areas of the lung to try and find a difference in ultrasound image between end expiration and inspiration. So and you don't want to find that. That might be a signal that you need to recruit more. So it would be very, very cool if we could also use lung ultrasound to detect overdistension in mechanically ventilated patients. And there have been some attempts at this, most prominently trying to quantify the strain of the pleural movements by speckle tracking. And this has recently been correlated to overdistension indices as quantified by electrical impedance tomography. So you can probably have a whole discussion about that, on how good that would be, but at least there is a good correlation here. And very interestingly, and also recently, a group tried to quantify the movement of the so-called Z line. So it's not a B line, it doesn't extend all the way to the periphery, but a very small vertical line. And you can, if you do an end expiration and expiratory hold, and you can see the movement caused by the heart, the so-called lung pulse. And the oscillation of that could here be correlated, albeit in a big study, with overdistension. So if you have, in this case, you see a low PEEP with a very small lung there, so you have a higher distension and vice versa. So the real beauty of ultrasound, I think, is to develop a holistic strategy of setting the ventilator by taking into account all the other effects that ventilator settings might have, such as changes in CO2, which might affect intracranial pressure, cerebral blood flow, and of course the obvious reduction in venous return and therefore also cardiac output that can be associated with higher intrathoracic pressures. And what immediately also comes to mind then is multi-organ evaluation, because you probably need to balance perfusion with congestion and vice versa. So there's a whole lot of techniques that can do that. So very interestingly, the transcranial Doppler perfusion, that could be, and you might not think that that could easily relate to ventilator settings, but now you do. And obviously then the next level would be the venous access ultrasound. It's a concept that is now being widely taught. There's many misconceptions, but the VACI score, as you probably know, is based on the hepatic vein, portal vein, and intrarenal vein characterization. You can see the components of the score here. Basically, as the grades go up, it's indicative of increased pressure and therefore possibly decreased perfusion on the right side. And this all comes down to the concepts from when I was still doing a lot of microcirculation research, is that there's a huge pressure drop across the arteries. So the actual organ perfusion pressure is basically being guided by the pressure after the arterioles on the one side and the pressure in the venules on the other side. And the pressure on the venules have a direct relationship with all the pressures on the right side, which ultimately ends in the right atrial pressure. And then you can make the obvious deduction, and if you have higher intrathoracic pressures, your venous return, defined as the mean systemic funding pressure minus the right atrial pressure divided by your resistance in the veins, will be lower, and when the intrathoracic pressure will be lower, your venous return will be higher. So now there's usually some French person that will come up with these graphs, so you can also visualize this. So if you would have a Frank-Starling curve and a venous return curve, you would obviously change the position on that curve when you alter your mechanical ventilation, which is usually depicted like this. So in this case, your right atrial pressure would rise and your venous return and hence cardiac output would be lower. And the idea is that you can mitigate these changes by giving more fluids, so that you will return to a better situation. So that obviously also brings us to ultrasound to use as a means to predict fluid responsiveness. And there have been many studies on this. Probably the best is to do a combined expiratory and inspiratory occlusions and measure the left ventricular outflow tract velocity time integral, so you can see the variation. And all of this reminds us that the heart is still in the chest. So you need to take into account, when you set the ventilator, all the different effects of the pressures within the thorax and outside the thorax. And yeah, so this is obviously well known to you. So the differential effects on the alveolar vessels and extra-alveolar vessels related to the lung volume, meaning that we get a U-curve in the total pulmonary vascular resistance, and also a direct effect of a dilated right ventricle on the left ventricle, and also a decreased coronary flow as the right ventricle systolic pressure increases. Now, the beauty of ultrasound is that we can take this even one step further. So this is my final concept that I would like to introduce. Is this from the cardiology world. So if you have pressure volume loops, in this case from the left ventricle, you will see that there is an end-systolic pressure volume relationship, and the slope of that is basically a load-independent index of contractility, and here's the end-diastolic pressure volume relationship. So on the other side, and now we're going to talk about ventricular arterial coupling, there is the aortic, in this case, so the arterial elastance. So this is the slope of the systolic pressure divided by the stroke volume. And the idea is that these slopes should be approximately equal for a good functioning cardiovascular system. Because if I would increase afterload all of a sudden, you would see that the arterial elastance would steeply increase, therefore altering that ratio. So So we know from the literature on this that there can be many variations in the way these pressure volume loops look. So this is for the right heart, but that doesn't really matter. The idea is that you have a physiological concept in your mind on how to approach heart-lung interaction. And as suggested by Pinsky, there are multiple strategies depending on the elastance of the arterial side versus the elastance of the ventricular side. And if they're both normal, we can, of course, celebrate and go home. But if they're both low, we might need a vasopressor plus inotrope. So, and the beauty of this is that we can also influence this by setting our ventilator. So if the interthoracic pressure would be higher, the elastance on the aortic side will be lower for the left heart. But for the right heart, it will depend on what it will do to your lung volume. So in case of recruitment, it will be lower, but in case of overdistension, the arterial elastance will be higher. And the same goes in analogy for de-recruitment and less overdistension. So the beauty of this is that this can all be assessed at the bedside by ultrasound. So for example, this is for the left heart, so you need to do a stroke volume calculation and also an ejection timing, so you can see that in figure D. And there's even an iPhone app for this called iElastance, and you can just plug in the numbers and you would know what to do. And also if you need more pressure or less pressure in the thorax for the heart. And similarly for the right heart, it's probably even easier. So you can do a tricuspid regurgitation, so to assess the pressure in the right ventricle and do pulmonary flows, although that window is sometimes hard to find a relative change in volume. And so you can basically reconstruct the right ventricular pressure volume loop and take it from there. So if you think, and sometimes I think that too, that is a little bit too difficult, you can also just determine the TAPSA and the pulmonary arterial systolic pressure, and also related it to the concept of ventricular arterial coupling. So with that I conclude, because my only conclusion is that the ventilator settings are best informed by whole body intensive care ultrasound. So taking it all together, I thank you very much for your attention.
Thank you very much, and happy birthday. And we open for questions. Maybe I can start. One concern I always have with lung ultrasound to assess the effect of different settings, ventilation, etc., is that the lung moves, and it's always difficult to be sure that you are looking at the same part of the lung. For instance, when you show tidal recruitment or even the effect of PEEP, are we still looking at the same part of the lung? So that's a difficulty, which I also have for the inspiratory or expiratory muscle. I'm never sure we are looking at the muscle in the same position. So what can be done to ensure that we are looking at exactly the same place?
Yeah, so first of all, I will readily admit that you're completely right. I mean, that is of course an issue. So, but what can be done about that? So first of all, I think lung ultrasound should be seen in the context of many other diagnostic modalities we have. So we should not look at it in isolation. And I have a very pragmatical point of view in this regard, that more information is usually better than no information, right? But if you want to approach it more systematically, you could, for example, expand the classical 4 or 6 or 12 regions lung ultrasound to maybe even 36, 72 or whatever. So, but then you might as well go to the CT scan, right? So there's a certain trade-off in terms of information that you can deduce from it. And also, so my main area of research is in machine learning, and a very common finding is that we are observing only certain parts of the world, but still can make strong deductions. So I think the same is true here. So you need to pay attention to the caveats, as you outlined correctly, but don't throw away the baby with the bathwater.
Okay, thank you very much.
So let's move forward and have a pleasure to introduce Professor Dres from Paris, France. And today he will talk about ventilator-associated brain injury. Professor Dres?
Good afternoon. Thank you for the introduction, ladies and gentlemen. It's an honor for me to be here, and I really would like to thank the Committee of Organization for the invitation and the opportunity to discuss about a quite complex topic, ventilator-associated brain injury. So there are my disclosures. So I think to make a long story short, we could start with this publication that clearly reviews the literature and highlighted that delirium in mechanical ventilation is associated, from mechanical ventilation induced delirium in MV patient. This is on the left side of the slide. And you also see that prolonged use of mechanical ventilation is associated with delirium. So clearly, there is some deleterious effect of mechanical ventilation on the brain. And I think it's important to go a little bit in the physiology to better understand this close interaction between the brain and the lungs. So it's all about the control of ventilation, and basically, I'm sure you are well aware that there is two drive in the brain, the cortex for the voluntary drive. It makes us decide to take a deep breath, for instance. But of course, during the night when we sleep, we don't think that we have to take a breath, and that's why there is an automatic drive in the brainstem. And of course, there is a respiratory muscle that, for instance, the diaphragm is one of them, one of the main of the respiratory muscle. And between the drive and the muscle, we have the nerves and the neuromuscular junction. But if we have a better focus on the brainstem and the generation of the automatic drive, you may see on this slide that there are many factors that may interact and may provide and generate the final output, the drive that will create the diaphragm contraction. And among them, you see on the right side the stretch receptors in the lungs that provide information for the cortex, but also to the brainstem, and it explains this close interaction between the brain and the lungs. And to illustrate that, and to illustrate the potential injuries that mechanical ventilation may do in the brain, I think this study here is very interesting and illustrative. It is done in animals, in rats, ventilated rats, and you see that three groups of animals were observed, a baseline group of animals, so basically no mechanical ventilation at all. It's the control group. You have also on the second line the group of patients without PEEP and a tidal volume that could be considered as safe, 8 milliliter per kilogram of ideal body weight. And a group, the experimental group, with a very large tidal volume, 30 milliliter per kilogram. So, of course, in terms of effect on the lungs, we are not surprised. It is completely expected. If we look at the lung injury score, for instance, that is a kind of histological score, you see that both groups with mechanical ventilation are associated with an increased lung injury score, very high actually. You see between 8 and 10. And it was not the case for the baseline, the control group, of course, because there was no mechanical ventilation. But what is very interesting here is that if we look at the brain, here it's the thalamus, a very important area of the brain, of course. You see that there is no difference between the control group, the group of animals without mechanical ventilation, and the group of animals with low tidal volume, so what we could call the lung protective ventilation. But what is interesting to see is that the group of animals with high tidal volume is associated with brain activation, and potentially with a brain injury. So we can see that it is possible to see how the ventilation, mechanical ventilation, could be deleterious on the brain. But I think we have also other study, in particular this one that was conducted by Thiago Bassi. It's interesting because it's in another setting, still in animals, but larger animals, pigs, and during a quite long duration of mechanical ventilation, because you see it's 50 hours of lung protective mechanical ventilation. So you see on the on the left side of the slide, the lung injury score that is quite low. If you remember to the previous study with a lung injury score as high as 10, here it's very, very low because lung protective ventilation does work, so the lungs are not affected by mechanical ventilation. But again, if we look at the brain, and here is the hippocampus, you see that there is a difference between the animals that were not intubated and not mechanically ventilated and the animals that were intubated. There were more apoptosis in intubated patients, and you can see also on the right side of the slide a higher index of apoptosis in the group of animals that were associated, exposed to mechanical ventilation. And we also have some, it's just a few data, but it's still interesting to look at that. It's a very nice and elegant study published by this Spanish group. Here in this publication, there were data from animals, but also from patients, and they could observe what was called here, you see hippocampal apoptosis in ventilated patient as compared to patients who were not exposed to mechanical ventilation. So, of course, we can imagine and guess that many bias may exist when we do such a comparison, because here the data were obtained from patients who eventually died. So potentially there are many, many bias, but still it is interesting to see that there is, as in the experimental studies, differences in the brain as compared to patients with ventilation and a patient without mechanical ventilation. So we do have some plausible mechanism to explain how mechanical ventilation may be deleterious to the brain. Basically, there are two pathways. On the left side, it's what has been called as the neural pathway. And you see that different mechanisms could play a role. Parasympathetic mediation, for instance, the vagus nerve also could be involved. I already mentioned earlier the stretch receptors, but also we could imagine that bypassing the nasal airways when we intubate and mechanically ventilated patient could be also a way to reduce the interaction between ventilation and the brain. There is also on the right side the humoral pathway that is linked to cytokines, inflammation, of course, that is also very important in patients with sepsis, for instance. Of course, we can think about potential therapeutic approaches, and I will discuss that later on the next slide with phrenic nerve stimulation. That is a way to maintain the diaphragm active in patients who are sedated, but also by restoring a kind of physiological breathing, by maintaining a kind of nasal breathing in patients. But before to go that, I think it's important to mention sedation, because mechanical ventilation is quite if it's not always associated with sedation. And clearly sedation is a major confounder. So this is clearly something that we cannot completely rule out when we want to assess the relation between the brain and mechanical ventilation. This is one of among many studies that highlighted the role of sedation. And here it's the time in birth suppression on the x-axis. You see with the risk of delirium or with the resolution of delirium. So to illustrate the potential of phrenic nerve stimulation, I picked up this study again by Thiago Bassi, who has done a very nice study and very elegant design. It's a pig model with a normal lung, so it's not ARDS here. And the pigs were ventilated during 50 hours. Again, there was a control group with pigs without any kind of ventilation. But in two groups, there was mechanical ventilation plus phrenic nerve stimulation that was generated by a catheter introduced in the subclavier vein. And every cycle, every ventilator cycle were synchronized with a stimulator, or only 50% of the time. So what we have is that we have at the end of the day 4 groups of animals. You see on the left side, MV is a group of animal with only mechanical ventilation. It's highlighted in red on the left side. In blue, NV is a group of animal without mechanical ventilation. So it's normal ventilation. And between, you have phrenic nerve stimulation 100% of the time, or only 50% 100 of the time, meaning that only one cycle over 2 was triggered by the ventilator. And again, they went to brain data from histology, and they found that the group of patients with phrenic nerve stimulation 100% of the time had a similar pattern, very close to the group of animals without any kind of mechanical ventilation, meaning that the index of apoptosis was very, very low as the group of animals without mechanical ventilation. So I think it's really fascinating to see that, because by providing a mechanical ventilation and maintaining the diaphragm active, it is possible, potentially, it has to be proven in a patient, to reduce the potential harm of mechanical ventilation on the brain. So we could potentially do that in patient using phrenic nerve stimulation in synchrony with the ventilator. The idea would be to share the work of breathing to reduce the pressure transmitted by the lungs, by the ventilator to the lungs, and by maintaining active the diaphragm. So this is a study that we have conducted with Thiago Bassi when he was in Paris in an ARDS patient. So you can see on the movie a patient that is equipped with phrenic nerve stimulation. You can see the contraction generated by the phrenic nerve stimulation with a kind of hiccup. And we conducted this study in 4 steps: 1 hour of mechanical ventilation, 1 hour of mechanical ventilation plus stimulation, and then 2 control, MV only, and again mechanical ventilation plus stimulation. So here, all breaths were triggered by the stimulator. And with Thiago, we monitor the brain activity with EEG, and we found that by providing phrenic nerve stimulation was associated with an increase in gamma power spectral density. That was increased only during the paced session. This is again something very fascinating, because it would say that basically by providing phrenic nerve stimulation, we can kind of waking up the patient while they are still sedated, and potentially to reduce the effect of maintaining them sedated. So maybe because of the time, I will skip that. And just to finish with this slide, to say that I'm not sure that we know very well what is a VABI. As a clinician in the ICU, for us, the The visible part of the iceberg is delirium, agitation when we stop sedation and patients are not as they were before intubation. But probably there is something after that we cannot see in patients after the ICU. And it's important also to get back to them and see how they are going, because it could be associated with a cognitive impairment. And this is clearly something very important if we want to implement preventive strategy. So I also wanted to highlight this important point of view that is also a way to sum up the new priority for research that is ventilator-associated brain injury. You see that we do have some clinical manifestation, and I think a very important gap to fill now is to develop technique to monitor the brain activity at the bedside. Thank you very much.
Excellent, Professor Dres. Questions? Okay, Nicole?
Martin, a question about your work. It reminded me of NAVA ventilation. How does it compare to NAVA? Would you hypothesize that if you use that method, you would also have less brain injury? Or I know it's not the same, but it kind of similar things to it.
NAVA is. Thank you for your question. NAVA is more a monitoring tool, right?
Oh, it gives it initiates the will to breathe via stimulation of the diaphragm.
Yes, but it does not induce a contraction, right? And here, with the catheter we use or some other techniques that are available to provide phrenic nerve stimulation, it's possible to use that in a sedated patient, which is not the case in a patient with NAVA, right? Because there is no EDI, there is no activity of the diaphragm, electrical activity of the diaphragm. Here, I think this is the most interesting aspect, is that you can obtain diaphragm contraction in a patient who is completely sedated. Of course, he should not be paralyzed, right?
Thank you.
Please.
Delirium in a ventilated patient could be due to various reasons. So, and I'm not sure whether the delirium could be considered as a ventilator-associated brain injury directly, or it's an indirect effect. So what is your take?
No, it's a good point. Is or not delirium a clinical manifestation of VABI? You know, since years we defined VILI, we defined VIDD, we defined VABI. So are we sure of what we define? I don't know. It's a very good point. I think that what we do know is that the most severe patients who were on mechanical ventilation and were associated with many confounders, in particular sedation, very often they have delirium, right? So they may have something between mechanical ventilation and delirium, but a direct causality, I don't know. But we do have some indirect evidence, for instance, from the experimental data, suggesting that mechanical ventilation itself, without the confounding factor of sedation, may cause direct injury in the brain. So I think that we cannot ignore that.
What's your opinion related to the arterial blood gases? We know that hypoxemia and hyperoxia may induce vasoconstriction, brain, as well as I told you, I'm old, so I ventilate my patients with high-minute ventilation in order to induce a reduction in CO2, and now we know that's not good. And what's your opinion? Do you think that we indeed have to control the arterial blood gases, you know, or because there are some papers showing that probably we may use a different strategy in order to reduce the PCO2 at the initial phase. What's your opinion in order to protect the brain? Do you think that we have to change our strategy, focus on this issue?
It's a very complicated question.
Oh, sorry.
No, you're right. You're completely right. I think we should not change everything we do because we have some new and experimental data. I think for me, the urgent task is to develop monitoring tool that would allow us to understand what is going on. Because this is clearly the iceberg. We just don't see what happens to the brain. We do have some new techniques, but it's not always easy to use. But we don't know. And you mentioned ABG. I completely agree with you regarding the fact that being too strict maybe could be harmful. But there is also cardiac output, for instance. The regulation of the cerebral blood flow is also a major point here. Yeah. So there are many confounders. That's why I think it's important to monitor EEG, potentially NIRS as well. That could be a way to understand the effect of our intervention on the final product.
Final short question and short answer.
I'll just shout. Hi, Professor Dres. It's Michel Slama from Oxford University. Just a quick question. Do you think we could use something like EMG to measure nerve signals that go back up instead of just EEG?
EMG is for the muscle, right? So EEG, we are talking about brain activity. So if we want to assess a kind of interaction between brain and muscles, why not? Yes, I think EMG could be interesting, but maybe I did not completely understand the question. Because EMG is just the final, it's the final product after the neural output.
Okay. Yeah. Okay. Thank you so much.
Thank you.
Fascinating. Thank you. It's me. My pleasure to introduce Michel Slama from Amiens, who is going to discuss ventilator-associated cardiac injury.
Thank you very much, Laurent, and thank you for the organization committee to invite me to speak about the heart-lung interaction, in fact, and the effect of the mechanical ventilation. So you know that sometimes, most of the time, the heart and lungs are living in perfect harmony. You know, it's good, so there is a lot of love here. But sometimes, the lung takes too much space and the heart is fighting to survive. So we know for a long time that to improve the oxygenation or in ARDS patients, you have to open the lung by mechanical ventilation, high PEEP, and recruitment maneuvers. It was demonstrated by many authors that if you apply a high PEEP, so you will decrease the collapsed tissue of patient with ARDS. And we demonstrate with Clément Bros that using TOE it's possible to assess the effect of the change of the PEEP on the lung. Just looking at the screen, you see that you have a consolidation on the left, and this consolidation disappeared with a high PEEP of 15 centimeters of water. But for a long time, for example, said that the workload imposed upon the right ventricle by elevation of the pulmonary vascular resistance may be a factor limiting the survival in ARDS. That maybe explain why, if you look at the meta-analysis comparing studies which compare the high PEEP and low PEEP, there is no effect on the mortality. And that's why maybe as well the ART study demonstrated even higher mortality, and it was due to hemodynamic impairment. It was really clear. And then if you accept that, how to assess this cardiac effect of the mechanical ventilation by using transthoracic and TOE, a transesophageal echo. It's possible to assess the left ventricle, the right ventricular function. You can assess the presence of fluid responsiveness. And with Pablo Mercado, we demonstrate that a transthoracic echo is very accurate to assess the cardiac output, the pulmonary artery. And with Clément Brou, we demonstrate that it is possible to assess the PAOP. So using echo, which is very accurate, you can have a real hemodynamic tool to assess the effect on the heart of the mechanical ventilation. And with Antoine Villard-Baron, we put some small probe, TOE probe, that we can let in the esophagus for 24, 48 hours, 72 hours to follow the function of the heart during mechanical ventilation, PEEP trial, and recruitment maneuver. Then to understand well which is the effect of the mechanical ventilation, you have to know that high PEEP and recruitment maneuver and even mechanical ventilation during mechanical insufflation may increase the right atrial pressure, which is responsible in part to decrease of the cardiac output. And by increasing the right atrial pressure, of course, you will decrease the venous return. It was well demonstrated. But this effect, of course, depends on the volume status, on the effect on the right ventricle Frank-Starling curve, on the lung compliance. And look at that. If you apply a recruitment maneuver in patients with hypovolemia, so you have a real drop on the cardiac output. In contrast, in patients with a normal volemia, or if you infuse some fluid to the patient, so the effect of the recruitment maneuver will be huge if you do it in a patient with hypovolemia. Then you have to avoid severe hypovolemia before increasing PEEP or performing any recruitment maneuver. I will show you that one of the main effects of the mechanical ventilation, high PEEP and recruitment maneuver, is on the right ventricle. This old study demonstrates that the cardiac output decreased during a PEEP trial, and it is in a part due to an increase of the pulmonary arterial systolic pressure, which is the afterload of the right ventricle. And then, because the right ventricle is very sensitive to the afterload, you can see here that if you increase the pressure of the pulmonary artery by only 20 millimeters of mercury, you will induce a profound drop of the stroke volume, in contrast with the left ventricle, which is much less sensitive to the afterload. And for a long time, so the team of François Jardin and Antoine Villard-Baron demonstrated that if you increase the pleural pressure, of course by increasing the pressure into the lung, so you will induce right cardiac dysfunction by increasing the end diastolic pressure into the right ventricle. And I like this study because demonstrating that during a recruitment maneuver, you increase the CVP, as it was demonstrated in animals, increase the mean pulmonary arterial pressure, and then the consequences is that you decrease the right ventricular preload, you increase the right ventricular afterload, and the effect on the cardiac output is to drop this very much the cardiac output, as you can see on this slide. So why do we have this effect? The hypothesis is that if the patient is not responder, if the patient doesn't open the lung during insufflation, during PEEP, high PEEP, or in recruitment maneuver, what happens? It means that you induce an over-distension of the lung, which is already open, and you will scratch, you will have an effect on the capillaries, and then you will increase the pulmonary arterial systolic pressure, increase the afterload of the right ventricle, and inducing an acute copulmonary, as you can see here, a large, huge right ventricle, which compress the left ventricle, and of course the consequence is really an impairment of the hemodynamics of the patient. And the team of Villard-Baron demonstrated that during the insufflation, higher is the PEEP, higher will be the effect on the afterload of the right ventricle, of course, inducing an impairment of the hemodynamics in the patient. Just to show you something you can see, of course, sometime in patients that a huge right ventricle and paradoxical septal motion, which corresponds to an acute corps pulmonale. And the problem is that when you do the recruitment maneuver, it's exactly the same. Look at the size of the right ventricle is huge when you apply your recruitment maneuver. And we demonstrate with Pablo Mercado that when you do this recruitment maneuver, even if it is transient, so you increase the size of the right ventricle. And you impair the true systolic function of the right ventricle assessed by the TAPSI or assessed by the ventricular longitudinal strain. Here, it's the right ventricular true systolic function which is impaired during the recruitment maneuver. And the problem is with all this effect, you may induce an acute corps pulmonale in 25 to 50% of cases. And the problem is that it affects the mortality. If you have an acute corps pulmonale, you will increase the mortality despite maybe you improve the survival by improving the lung. But by inducing acute corps pulmonale and more severe is the acute corps pulmonale, higher will be the mortality of the patient. But you don't have only an effect on the right ventricle. You have as well an effect on the left ventricle. And it was well demonstrated a long time ago by François Jardin, his beautiful paper in the New England Journal of Medicine of 1981. And then, of course, if you look at that, you understand that a big right ventricle will compress the left ventricle, which will be very small. And François Jardin and Antoine Villard-Baron demonstrate that by increasing the pleural pressure, you decrease the size of the left ventricle, and then you decrease the ejection of the left ventricle, and you induce left ventricular dysfunction here with the left ventricular and diastolic pressure, which increase. With Pablo Mercado, we demonstrated by assessing the longitudinal strain of the left ventricle that by inducing a recruitment maneuver or increasing the PEEP to the patient, we will have an impairment of the true contraction of the left ventricle. And why? One of the reasons is here. We did with Johan Zerbib the assessment of the coronary flow of the right and left coronary arteries at 5 and 15 of PEEP. And look at that. The diastolic flow, you know that the left coronary artery has a higher flow during diastole than during systole. You can see it on the left-hand side of the slide here. And then when you increase the PEEP to 15, so you decrease this diastolic flow as well as you decrease the systolic flow into the right coronary artery. So you have this equilibrium, this balance that you can have between the heart and the lung. If you really want to improve the survival of the patient by doing your mechanical ventilation, putting a good PEEP, a right PEEP, and doing maybe a recruitment maneuver. But which is very interesting, is when you compare patients who responds to the recruitment maneuver and the patient who doesn't respond to the recruitment maneuver. Look at that. The drop of the cardiac output is much lower when the patient is responder. And how to explain that is maybe due to the change of the compliance of the lung, and I like very much this paper, demonstrating that in a non-responder patient, the elastance of the lung doesn't change, and if you look at the cardiac output, you have a real drop of the cardiac output from 10 to 6. In contrast, if the patient opens the lung, if it is a responder patient, so at that time, you have almost no change of the cardiac output during the recruitment maneuver. So how to explain that? If you don't open the lungs, so you compress the capillaries, In contrast, if you open the lung, so you have no more compression of the capillaries and you have no more effect on mainly the right ventricle. And we demonstrate this hypothesis again with our team. So if you apply the same PEEP at 25 before and after recruitment maneuver and when you open the lung, so all the left and right cardiac parameters improved after the recruitment maneuver. And I love this study from the team of Jean-Louis Teboul and Xavier Monet, who exactly say the same thing. If you look at the pulmonary vascular resistances in a high recruiter, so you have no change of these pulmonary vascular resistances. In contrast, in patients in which they are low recruiters, in which the pulmonary vascular resistance increased dramatically, and it was the same for the assessment of the right ventricle in a high recruiter, so and the low recruiter, you have a different change. And I like this last study that I would like to show you because it's really the demonstration that if you apply the recruitment maneuver and you don't open the lung, you will induce hemodynamic failure of the patient. But in contrast here, you will see that by creating experimentally in a pig a small lobar atelectasis, you can see that on the CT scan, and then they apply a recruitment maneuver, a general recruitment maneuver in the lung, and so you have a drop of the cardiac output. In contrast, when they have done a selective recruitment maneuver on the atelectasis, so you have no change of the cardiac output. So maybe in the future, as we have shown with many friends like Clément Brault, that we may use this recruitment to inflation ratio to select the patient in which we can do the recruitment maneuver. And look at that. It's very interesting to see that by using this ratio, we can select this kind of patient who will have a good response to the recruitment and a high PEEP, and for which you will not have any effect on the cardiac output and on the heart. So to conclude, TE and TTE are the most useful tool to assess the cardiac function at the bedside, as you know. And then you have to check the heart-lung interaction in patient under mechanical ventilation, because the mechanical ventilation, high PEEP and recruitment maneuver may induce right ventricular dysfunction and left ventricular dysfunction. And the consequence could be the acute cor pulmonale, which increase the mortality. And then again, you have really to do a balance between improving the lung in one way without inducing an impairment of the heart, because at that time you will have either a neutral effect on the mortality or you will increase the mortality of your patient by inducing an impairment of the heart with your mechanical ventilation. So thank you for your attention.
Thank you very much, Michel. We have time for questions. Is there? Yeah.
Thank you very much for the presentation. My name is Tomás Fariña from Madrid. In hemodynamic management, there's a topic of the arterial elastance, the relation between the blood pressure variation and the stroke volume variation. Is there a place to do the same in the arterial, in the pulmonary arterial field? I mean, can we measure the pulmonary arterial vascular elastance?
You mean the coupling? Yes. Yes, of course. I think that Paul Elbers shown you that it is possible to assess the coupling on the left ventricle as well on the right ventricle by using echo. That's very, very easy, very useful, because with echo you can assess the contraction of the right ventricle, which is one part, which is the cardiac elastance, and you can have the pulmonary arterial systolic pressure, which is the afterload of the right ventricle, which is mainly the elastance. So you just keep in mind that the elastance right and left for the heart are mainly due to the resistances, okay? Then if you record the pulmonary arterial systolic pressure, and if you can have an access to the pulmonary resistances, you can do a coupling and to check if you have a good point between the elastance of the pulmonary artery and the cardiac elastance, okay? But if you just have an idea about the pulmonary arterial systolic pressure and the strain, for example, the contraction of the right ventricle, so you have a good idea about the coupling between pulmonary artery and right ventricular systolic function.
And that could be helpful to predict, for example, hypotension in the maneuver.
I don't know. I don't think that there is any paper which, for which it was the goal of the study, demonstrating that by using this coupling, you may maybe improve the patient or decrease the mortality. So, of course, theoretically, yes, you can do that, but okay, you have to do this research now, this clinical research.
Michel, a quick question. The European guidelines and the ATS guidelines on ARDS, they disagree on some points, but they agree on strongly recommending against recruitment maneuver.
I know.
What do you think from your hemodynamic standpoint and experience?
Yeah. I understand these recommendations coming mainly from the RT study. I have many criticisms, as we already discussed, about this ART study. So if you put 60 centers to do a recruitment maneuver, which is very hard, very difficult to do the recruitment maneuver as Marcello Amato is doing. He has a lot of experience. So I'm sure that you are killing some patients. But a part of that, I think, and you have seen during this presentation, that in a group of patients, maybe who will respond to the recruitment maneuver, I'm sure that you may improve not only the lung, but as well the heart function, and you don't induce any acute cor pulmonale in this patient when you do the recruitment maneuver, and after you can set a high PEEP without inducing acute cor pulmonale. And really, I feel that the mortality of the comparison between high PEEP and low PEEP is due to the cardiac dysfunction.
Okay, thank you very much, Michel.
Thank you so much.
Now it's my pleasure to introduce Professor Nicole Juverman. She's from Amsterdam, Netherlands, and she will talk today about ventilator-associated increased risk of thrombosis. Nicole, the mic is yours.
Thank you, Patricia. I have no disclosures for this talk. So you are well aware of the high risk of thrombosis in mechanically ventilated patients. It was in our faces during COVID, but it's not confined to COVID alone. It's also present in other cohorts of ARDS, and in fact, the high incidence of thrombosis is higher in ICU patients, whatever their underlying factor, when you compare them to ward patients, which tells us that it's really the disease severity that is driving this risk of thrombosis, and probably this is inflammatory driven as well. So if you take an active screening approach with ultrasound, you will learn that these thromboses, they consist of both pulmonary emboli and deep vein thrombosis. And yeah, when we go back, Virchow in 1859, he invented the terms thrombosis and emboli while examining corpses of diseased patients, and he found thrombosis in the legs, and he also found distant thrombosis that he termed emboli. And that is where we are today. We tend to think of deep vein thrombosis and pulmonary embolisms as being different manifestations of the same disease. I will tell you today that this is probably not true. There are reasons to believe so. If you look into a cohort of hospitalized patients with pulmonary embolism and you start screening them and looking for where this deep vein thrombosis is, you will only find deep vein thrombosis in a minority of patients. But then some people may argue, well, but if you start looking, maybe the deep vein thrombosis by that time has dissolved or something, and it's still, the pulmonary embolism arises from a part of the thrombosis that has left loose. But there's also other evidence that has more recent, and this is from a very large cohort of trauma patients, more than 1,000 patients that were followed up for the development of pulmonary thrombosis, and all were screened for having deep vein thrombosis as well. So they divided the cohort in having pulmonary thrombosis without deep vein thrombosis and those with pulmonary embolism with deep vein thrombosis. And what they found was that the risk factors for developing pulmonary thrombosis in the absence of distant thrombosis is having a thoracic blunt trauma, so a direct trauma on the chest, or shock, or low flow, if you will. And these risk factors did not drive the development of pulmonary embolism. In fact, those were other risk factors, such as fractures of the extremities, that were associated with the development of deep vein thrombosis and pulmonary embolisms. So then we started to think maybe these are different disease entities. And we looked at the histology of patients that had died from COVID, and we started to examine the kind of thrombosis that they had in their lung. And this is an example of a classical embolus from a patient. You can see that it's a kind of a rounded thrombosis. It's very careful layered between fibrin and the red blood cells, and it's in the middle of the vein. In contrast, in a patient that has in situ thrombosis, that kind of thrombosis originates from the cell wall, and there's a lot of infiltration from, in that space, and it's not layered at all. It's a big mess. So histology speaking, these are really very different entities. So that led us to dive a little bit deeper and look into a cohort of all ARDS COVID patients from which we have this histology, so histology-proven differences between the type of thrombosis. And we also looked whether we had blood samples of them, so we could measure biomarkers, and whether we had CT scans to look at the clinical imaging of those different kind of thrombosis. So it's a small cohort, but nonetheless, these are your average ICU patients, so middle-aged males with a bit of overweight. We had 3 days between the blood sample and the day that they died, and we had the histology, and 8 days between the CT scan and death. So, and then we did some analysis of the host immune response in patients, and we found differences that actually make sense. In the sense that patients with in situ thrombosis have higher levels of IL-4 and IL-18, and these are cytokines that are associated with the T helper 2 pathway that is associated with a decrease in clearance of viral infections. So there is skewing of the Th1 Th helper 2 ratio towards Th helper 2 associated with a decrease in viral clearance, which was present in those with in situ thrombosis, but not with pulmonary emboli. And then we took a look at the CT scans. We had radiologists evaluating these, and they also found differences. So typically, patients with pulmonary embolus would have their thrombosis in central pulmonary arteries, and they would not be in proximity, so not in close neighborhood of infiltrations. Whereas in situ thrombosis, it's much more segmental or subsegmental. It's thrombosis that is along the vessel wall, and it's in close proximity from pulmonary infiltrates. So also, on the account of imaging, there were marked differences. So this leads us to believe that pulmonary thrombosis and pulmonary emboli are distinct entities. And then we took it a step further, starting to think, what are the risk factors? And the reason that we are doing that is because the risk of development of pulmonary thrombosis increases with your time in ICU. And this is a graph of COVID patients in the first wave when we didn't have any therapy that was helping them. And that's why this amounts up to 80% of patients having pulmonary thrombosis after 3 weeks. That is now, of course, much lower, but it's just to serve to highlight the fact that the risk of thrombosis increases with the time you spent on ICU. So what are the risk factors for that? And remind you, they were all on prophylactic low molecular weight heparin, so obviously that doesn't help for the risk to mitigate the risk of development of pulmonary thrombosis. So if we start thinking about the risk factors, we can again turn to Virchow. And you know, of course, his triad of the development of thrombosis, which implicates endothelial injury, hypercoagulability, and stasis of blood flow. But we usually talk about this in reference to deep vein thrombosis, but we can also talk about this in references to pulmonary thrombosis. And I think we've spoken a lot about endothelial injury and vascular permeability, and a lot about how the coagulation balance goes haywire in COVID. Let's leave that alone and focus on the stasis of blood flow. And in case of pulmonary thrombosis, we are talking about the pulmonary blood flow. And in fact, everything that we do as a clinician in ICU is all the knobs that we turn, they influence the pulmonary blood flow. So to remind you, the pulmonary circulation is a low pressure system, and it's easy collapsible, as the previous speaker also alluded to you, if you increase intrathoracic pressure with positive pressure ventilation, either with high peak pressures or high positive expiratory pressures. You can easily decrease the pulmonary perfusion and induce stasis of the pulmonary blood flow during your mechanical ventilation. But it's not only the pressure set on mechanical ventilation, it's also everything that we are modulating. It's mean arterial pressure, it's cardiac output, it's the amount of fluids, whether we keep them restrictive or a bit more liberal. All of these knobs that we turn on, these modifiable risk factors, they impact the pulmonary blood flow and hence the stasis in the lungs. So we set out to explore this in a cohort of COVID patients, again, because this is a homogeneous disease, but it's probably also applicable to every kind of respiratory disease. So we took patients from 4 hospitals, nearly 2,000 patients are there, and we followed them up, and until the moment they were, so let's say they were included in this cohort if they did not have pulmonary thrombosis upon ICU submission, and then they had to be 2 days on the ICU, and then we followed them up for the development of pulmonary thrombosis, and once they had thrombosis, they left the cohort. So this gave us 8 days between ICU admissions and the development of pulmonary thrombosis. And this is the breakdown of the patients with pulmonary thrombosis, yes or no. There's not much difference between age, male, BMI, SOFA score, etc., although there was a higher CRP in the patients that developed pulmonary thrombosis. And then we set out to compare the ventilation settings, let's say. So CRP, it was high, it declined, it was higher in those with thrombosis, it declined in both groups when time progresses. I think we can understand this. SOFA score was the same at the start, but it declined earlier in those without any thrombosis, whereas it remained the same throughout the first 21 days in those that developed pulmonary thrombosis. So what about ventilatory settings? The tidal volumes were the same. We are very, mature in how to apply protective ventilation with low tidal volumes. So that is what's being done in all these 4 ICUs. But peak pressures were consistently higher along the time course in patients developing thrombosis versus those that did not develop pulmonary thrombosis. And also PEEP was consistently higher in patients that went on to develop thrombosis compared to patients not developing thrombosis. PF ratio was lower in those with thrombosis, and this speaks to the fact that hypoxia strongly drives a procoagulant response. So also here was a difference. The fluid balance was not so much difference. It was a little bit less in the first 2 days, but there was a lot of overlap between patients. So then we tried to take a little bit further. a little bit further than just comparing the means between two groups, and even a little bit further than saying something is associated with something else. Here, we actually try to make a causal inference. So this is a kind of a graph in which you can look at it for a long time, but this is how we imagine the chain of events that lead to, that influence the pulmonary blood flow and lead to pulmonary thrombosis. You have, of course, your patient-related risk factors, you have your therapies, and somewhere there is also your fluids and your vasopressors, and of course everything is related. But we try to put this in a graph and then do causal inference statistical analysis with this. And when we came up with this, we actually also found that increased PEEP increased the odds of development of pulmonary thrombosis. And this may seem as a clinical not meaningful increase, but it's per centimeter of water. And the same holds for the peak pressures. We didn't have any data on proning, the length of proning, so we decided to leave it out, but there have been 4 other studies that have looked into this. They have compared patients that were prone versus patients that were not prone, and they consistently found a 2 to 3-fold increased risk of developing pulmonary thrombosis. And this was, as you will, a dose-dependent phenomenon. So it depended on how long the patients were prone, and also probably this relates to low flow in the pulmonary veins. So the next question is, what does this mean? What is the implication for our clinical practice? Is in situ thrombosis always a bad thing? And I guess this depends. If you have a healthy alveolus with no RDS in it, and you develop a thrombosis there, for sure you will have an increased dead space, and that will develop into hypoxemia. However, if you have a flooded alveolus and you there develop your thrombosis, you actually may not deteriorate in your shunt fraction, your VQ mismatch, and there is no hypoxemia. It may even improve. And as you all know, there are good and bad parts in ARDS lung. So how does this add up? I guess it's unknown. And so you can ask yourself, okay, should I then avoid a high PEEP, even if it's good for the ARDS, in order to avoid in situ thrombosis? Is that what you're saying? I'm not saying that. I would say that perhaps avoid unnecessary high PEEP or decrease your PEEP when your patient is improving. The other question that you can ask yourself is that we also should be always prone for 5 days, or can we do it a little bit less? And then I guess maybe what comes up in your mind as a question may also be, should we anticoagulate in situ thrombosis, right? We have some data on this. Again, it's in COVID, in which patients were randomized, large amount of patients, to anticoagulation with heparin or not. And if you anticoagulate COVID patients with pulmonary thrombosis, of course we don't know what kind of thrombosis they had, but if you anticoagulate the whole group, you will find a decrease in the amount of thrombosis. Okay. But you will not find a decrease in the thrombotic-driven risk of dying. That does not decrease. And you will, as always, if you start anticoagulation, you do have a little bit of increased risk of bleeding here. So it's a weighing of risk and benefit here. So I would say it's not known. Probably not if it's subsegmental. And if you have this, weigh it against the bleeding risk. So with that, I conclude. I think I may have brought you more questions than answers, but I think it's a novel way of looking. I think we should be aware that there can be different kinds of thrombosis in the lungs of our patients. There are risk factors for in situ thrombosis. There are modifiable potential. How to modify them and receive optimal management is yet unknown. And with this, I would like to thank you for listening.
Questions? Okay, so.
Coming.
Thank you. Excellent presentation. Just I'm wondering, you have chosen CRP instead of D-dimer in a embolism. Is there any particular reason?
I didn't choose CRP as just a descriptive parameter. I'm just showing that there is a difference between the two groups. Your question about D-dimer, for sure, I didn't show it, but for sure, D-dimers is higher in patients with pulmonary thrombosis versus those without pulmonary thrombosis. Whether D-dimer is distinctive between in situ thrombosis and pulmonary embolus is unknown, I think, at this point. But it's we should look into that. Good suggestion.
Excellent.
Nicole,
Yeah.
thank you very much. That was really a different perspective. So I remember the first papers by Warren Zapel in ARDS. He showed that using the balloon inflated by the Swan guns, he was doing a very regional angiogram, and he showed a lot of pulmonary defects. However, people said, well, these were mostly trauma patients, and the discussion was, well, maybe it's specific to trauma. So did you look at that, the trauma versus non-trauma?
Yeah, so I showed you some data. I think I don't know if you experience this in your clinical practice, but we have experienced a huge change in the aggressive resuscitation of trauma patients. They receive tranexamic acid and fibrinogen on the street, and now they often come already on day one with pulmonary thrombosis. So for sure, this is not related to any fracture of extremities, and especially as I showed the study, also if they sustain blunt trauma, so a trauma there. But I don't think that it needs to be that there needs to be a trauma, given that in COVID patients, obviously there's no mechanical factor there. It's probably highly inflammatory driven. And it may actually be a protective mechanism of the body itself, quite similar to hypoxic vasoconstriction, that the body may, clot the pulmonary arteries that lead to alveoli, which are flooded anyway. So it may be a protective mechanism. And at least I think it's an explanation of the finding why anticoagulation in COVID, in which in situ thrombosis is probably highly prevalent, so anticoagulation in that cohort is not effective. So I think we should try to, and we are offering a phenotype that is of pulmonary thrombosis that is recognizable at the bedside. So I think we will in the future be able to distinguish between the two.
Nicole, only to contribute to your study, we published a paper recently in proteomics in mild COVID and severe COVID, and we observed that in severe COVID, we have more biomarkers associated with endothelial cell dysfunction, and we have more thrombosis.
Great.
And so the endothelial cells, indeed, is an important mechanism, an important pathway to stimulate the more embolism compared to other patients.
Yeah, agree, yeah.
So let's move forward, Professor. It's your turn. Thank you, Nicole.
Okay, the next presentation is about ventilator-associated kidney injury by Peter Pickers from Nijmegen.
Thank you very much, and thank you for having me again in this beautiful meeting in Brussels. Ventilator-induced kidney injury, VACI. Is this a thing? Actually, it is. If you look at studies in which patients are ventilated or not, mechanical ventilation is associated with a threefold increase in the development of AKI in patients in the ICU, even if you correct for all kinds of other factors. And it doesn't seem to matter much what the reason is for mechanical ventilation. All these subgroups show higher risk or higher incidence of AKI if mechanical ventilation is used compared to those that are not ventilated. So we went back to of the first description of this interaction between mechanical ventilation and the kidneys. And I found this publication out 1947 in the Journal of Clinical Investigation. And what they did, they had 4 healthy volunteers, and they were submitted to 30-minute periods of continuous pressure breathing at 10, 20, 30, and 40 millimeters of mercury. And what they found actually, that if you do that within very short time, renal clearance, so renal function, is actually going down to a great extent. And so they found that up to 60 millimeters, nothing much happened, but if it was higher, then this was an effect. And at pressures at 25 or 40 millimeters of mercury, circulatory collapse happened, of course, and fainting became frequent. So this is also, I love to read that old stuff, old school discussion section, you gotta love it. The kidney circulation is early reduced in conditions that embarrass the general circulation. And the question might be raised as to the wisdom of the body in sacrificing kidney function. So in these times, actually, if you would say that one organ is embarrassing the body, or that it's wisdom that one of them would actually be sacrificed, it's clearly that the body is an unsafe working environment for the organs. And if it's a wisdom to actually sacrifice kidney function, that's not clear as well, because we now know that if there's an increase in creatinine as a consequence of AKI, the odds ratios to die are increasing tremendously. So AKI is associated with mortality, so I'm not sure if this is the wise thing to do, to sacrifice kidney function. How does it work? Is it just pressure-induced effects on macrocirculation? Well, indeed, we do know that if you measure oxygenation, saturation in venous vessels coming from different organs, for example, it's 37% in the heart. So that means that the heart is really, really good in getting oxygen off hemoglobin. But in the kidney, it's 92% venous saturation of venous vessels from the kidney. That means that the kidney is not good at all in getting oxygen from the hemoglobin. And that means that the kidney is very much dependent on cardiac output. And we do know indeed that about 25% of cardiac output goes to the kidneys. So this is macrocirculation, of course, that is influenced by pressure, and I will come back to that later. But also we know about renal microcirculation, and we do know that PEEP, for example, has effects on the distribution of renal blood flow within the kidney. And so this is a monkey, and also an old study, a monkey study, and they were put on pressure support, and they measured total renal blood flow, and indeed it decreases. But actually, if you look at the outer cortex and the inner cortex of the kidney, the decrease of the outer cortex is much more pronounced than the decrease in the inner cortex. So indeed, there are vascular microcirculatory effects that actually determine blood flow within the kidney, and these are also influenced by PEEP. So we are talking about the arterial side. So we have macrocirculation and microcirculation within the kidney. But what about the effects on the venous side? So we do know that positive pressure ventilation is altering venous return and cardiac preload. And this is mostly found in observational studies in sepsis patients. And if you look at the CVP, so the central venous pressure, there is almost a linear relationship with the risk to develop AKI. So it's not only the amount of blood and the cardiac output that is actually delivered to the kidney, and that could be less during hypovolemia or other reasons, but also a higher CVP is a risk factor to induce AKI. And this is already occurring at CVPs of 6 or 8, very low, normal levels almost of central venous pressure. What's the reason for that? Well, the reason is that the kidneys are in a capsule, and that means that there's no room for an increase in pressure. And if you look at the glomerulus, the actual pressure in the blood vessel there is 45 millimeters of mercury. And then there is already a pressure of 10 millimeters of mercury in the capsule, so that you have a driving pressure of 35, and then you have a mean colloid pressure of 25. So that means that the driving pressure to actually produce urine is only 10 millimeters of mercury, this big. So there's very little driving pressure. So if there is a reason that the venous outflow of the kidney is compromised and that pressure goes up above 10, that will mean that this whole driving pressure to produce urine is gone. And so that's the reason why central venous pressure is also a reason to actually induce AKI, that this venous return is compromised of the kidney, and then you get congestion and less urine production. So mechanical ventilation is increasing intrathoracic pressure, of course, and this has effects on hemodynamics, and the venous return to the heart is less, and as a consequence of that, you have venous congestion, and the central venous pressure goes up, and as I explained, this is already a reason to develop AKI. But another consequence is if the venous return to the heart is less, that cardiac output goes down, and of course then you will also have less perfusion of the kidney, and so from both sides it's actually hurting the kidneys. And you also have neurohormonal effects, so mechanical ventilation has effects on several hormones that actually co-op, and that has effects within the kidney. And so the perfusion of outer and inner cortex becomes compromised, renal blood flow and GFR goes down, and that results in fluid and salt retention as well. So these are the mechanical ventilation-induced effects on the kidney that all induce a decrease of renal function. But there's more, inflammation, of course. Everything is inflammation. And this is a very nice follow-up study of lung protective mechanical ventilation studies. So only 18 patients against 19 control patients. They had tidal volumes of 8 versus 11. PEEP was higher in the lung protective group, 15 against 7. And what they did, they measured inflammatory mediators, so cytokines in the ball fluid. And what they found that in the ones that were not ventilated with a lung protective strategy, there was a similar or small increase of these inflammatory mediators in the ball fluid, while the lung protective strategy group showed a decrease. So the lungs are responding in an inflammatory manner on the way that they are ventilated. So this is a translational effect. And they did not only measure in ball, but also in plasma, and again, more mediators of inflammation. This is the ball fluid, and this is the plasma. And you can see in the control group, there was an increase of inflammatory mediators, while there was a significant decrease of these inflammatory mediators in the lung protective strategy treated group. And we now know that indeed mechanical ventilation is inducing inflammation, and it's not only cytokines, but it's all kinds of parts and parts of inflammation, complement activation, etc., that are indeed induced, and they by themselves can also induce AKI. We know that there is a correlation against AKI as well. Does this have clinical consequences? It does. So we all know this trial, of course. If we look at outcome, there's a benefit of the lower tidal volumes group. But if we look at the number of days without failure of non-pulmonary organs, so the respiratory guys, this is what the kidneys are called by the respiratory guys, non-pulmonary organ. And indeed, there is a benefit. Renal failure, days with renal failure are less. But it's statistically significant, but it's only 2 days difference. So it's not a huge effect, but there is an effect that this does indeed have consequences on renal function and renal failure. So you might say, well, maybe if we allow hypercapnia to develop, this might cause problems, because acidosis is actually a reason, metabolic acidosis, to start renal replacement therapy. That's one of the conventional criteria. Metabolic acidosis. And there are many effects of hypercapnia, and most of them might actually be beneficial, as depicted on this left side, but there could also be detrimental effects, like depicted on the right side. And the thing is also, studies show that hypercapnia by itself correlates inversely with renal blood flow by stimulating noradrenaline release and inducing vasoconstriction. So that effect could also have potentially a detrimental effect on renal function. And then it's not only that mechanical ventilation might lead to AKI, it's also the other way around. Kidney injury and AKI will lead to acute lung injury as well. And there's also a lot of literature on that. And most of that detrimental factors that are described there are related to fluid balance. If you have less renal function and less potential to actually get rid of your fluids, clearance effects, renal replacement therapy effects, that might all actually induce acute lung injury. So it's a very complex interplay, as is depicted in this one as well. So I depicted a couple of aspects related to pressure and mechanical effects of mechanical ventilation on the kidneys from the arterial side as well as from the venous side, and also that mechanical ventilation by itself induces inflammation in the lung and that there's spillover to the bloodstream and that this might also lead to renal dysfunction. So my conclusions are that mechanical ventilation is a life-saving action, clearly, no argument. But these are complex machines, and if you do it not in the right way, it's always very dangerous pressured air. So in multiple ways, hemodynamic and inflammatory ways, pressured air might actually hurt the kidneys. And if you do use lung protective strategies, this is beneficial overall, but it's also beneficial for the kidneys. And with that, I thank you for your kind attention.
Thank you very much. Any questions? How do you diagnose AKI induced by congestion, venous congestion?
So the thing is that the diagnosis of AKI, we use the KDIGO criteria, and it's based on urine output criteria and creatinine increase criteria. But this actually is not deciphering any underlying endotype of what is the reason of the AKI. And so we now do recognize that there are very different ways that AKI may occur, but in the clinic we have no way of deciphering that. We do have in research that different biomarkers of tubular injury in the urine, for example, show different patterns, and some biomarkers go up with ischemic renal injury and other ones by venous congestion or inflammatory damage, etc. But this is far from clinical practice at this moment.
Because for the liver, for instance, looking at venous congestion is possible with ultrasound. So
yeah,
you
well,
don't do that for...
Yeah, I do think that what I showed you, the correlation with just the actual number of the central venous pressure, if it's getting higher and if it's above 10, 12, 14, it's very likely because your driving pressure is only 10 millimeters, and then your patient's diuresis is actually getting less, then it's very likely that this is actually a venous outflow issue. And what we see also in the clinic is that if you give a patient like that furosemide, and he starts to pee, and venous pressure goes down, you only give one dose of furosemide and he keeps on peeing. So this means that indeed this whole mechanism of driving pressure is actually beneficially influenced, and then you fix that part.
Okay, thank you so much.
Oh, thank you. So I'd like to thank you all for being here. This is our last speaker, and I hope to see you around during this fantastic meeting. And now we will have a plenary conference, and I hope that you can stay here. Thank you, Laurent. Thank you all for being here.